So let's go into what we call substance use disorder or drug use disorder. And so there are various terms or certain terms that we all need to understand how to interpret them, how to explain them. So we need to understand dependency. We need to understand tolerance. We need to understand withdrawal. We need to understand codependency. We need to understand manipulation when it comes to the use of substance. And so substance dependency is where an individual repeatedly use a certain, substance or a certain drug, which usually results in what we call tolerance. Tolerance is the need for the individual to increase the amount of the drug to be able in order to achieve the desired effects of the drug. Then we also look at the pattern whereby one repeatedly use what we call a certain drug. Okay, these medications, some of them are medications that are actually to be prescribed, but people tend to use it for various reasons. Some of them are not drugs that are prescribed, so people go based on whatever issues they have, they tend to abuse these drugs. So we need to understand that dependency has to do with the repeated use of a certain substance, which will usually result in tolerance. Withdrawal, we explain tolerance, we explain withdrawal symptoms, so don't worry about it. So, and then compulsive drug taking behavior. So the individuals engaging in certain behavior that results in continuous use of a certain substance or a certain drug. It's what we call drug dependency. And so let's say you have someone who takes alcohol, someone who is dependent on alcohol. Alcohol dependency means that the individual continuously takes alcohol. Almost every day, the person takes alcohol. Whenever the person stops taking alcohol for a certain number of hours, and then the alcohol is out of the system, the person starts to experience certain physiological and the psychological issue that has to talk about withdrawal. Then tolerance means that, let's say at first, the individual used to take just a bottle to be satisfied or to get the needed effect or the desired effect of taking alcohol. As the person continues to take the alcohol, it will get to a point the person will now have to increase the amount of the alcohol or the volume or the number of bottles the individual consumes in order to achieve the desired effects that at first the person used to take, let's say, just a bottle and be okay. And so that is on dependency. So that is on tolerance. So substances are taken in larger amounts and then over longer periods than was intended for. Yes, so maybe the person just felt like one day, let me just go and get some glass of alcohol. As time goes on, the person becomes used to it, and all the time the person has to go on the drug or go on for alcohol. Mostly people with alcohol intake or people who uses drug, they might have in one way or the other tried to stop the drug intake, but our efforts that they put in place does not yield the needed result. And so I always use this example. I was caring for this young lady around 17 years, and she tells me that she has been abusing tramadol for almost 2 years. And this time around, she came on admission that she wants to stop. We asked her, have you tried? She said, yes, I've tried several times myself, but I haven't been successful at it. And so almost all people who abuse a certain form of substance or drug, if you engage them, they will tell you that we have tried several times to cut down the intake of that very drug, but the efforts to decrease or discontinue are unsuccessful. So mostly they will need to come on board to be admitted in order to manage them very well before they can quit their intake. Almost all their daily activity revolves around the use of alcohol. Tolerance is the need to increase the amounts of the substance to achieve the desired effects. I think I have explained this that tolerance means that if first you used to take a bottle and to be satisfied or to get the desired effect of the reason why you are taking that very substance. As time goes on, you would have to increase the amount to be able to get that desired effect that affects. You can only use just a glass or a bottle to get. So the need to increase the amount of the substance to achieve the desired effect is what we call, substance tolerance. Then we look at withdrawal. If you understand these terms, it's going to help you very well. Then we look at withdrawal. Withdrawal is whereby the individual experiences certain physiological and then substance-specific cognitive symptoms related to when there is little amount of the drug in the individual's blood. So withdrawal occurs when the individual experiences a decrease in blood levels of a substance on which the individual is physiologically dependent on. So let's say that you are taking alcohol. You take the alcohol, you stop the alcohol for some day or for a certain number of hours. At a point in time, the amount of the drug in your blood is going to decrease. So the moment you stop taking the drug for some time, you realize that metabolism will take place and then the drug will be eliminating from your blood or from your system. So that means that the amount of the blood, the amount of the substance in your blood is going to decrease. And when that happens, then the individual start experiencing certain physiological and then certain cognitive problems. So for instance, if someone abuses alcohol and the person is withdrawing from alcohol or has stayed off alcohol for let's say 12 hours, you start seeing that the person will be, some do even hallucinate, some of them will be experiencing high body temperature, some of them will be experiencing tachycardia, hypertension, all because at this time, the amount of the drug or the alcohol in the person's blood is reduced because the person has stayed off from the drug for a certain number of time or for a while. And so if you are doing withdrawal management or if you are treating what we call substance misuse or substance abuse, you realize that they would have to introduce the drug the individual was taking at a slow dose. So let's say the person used to take, let's say, tramadol 125 milligram, and then you want to treat the substance misuse. The healthcare provider or the psychiatrist would have to introduce a certain amount of what we call the tramadol into the person. So we are not going to stop the tramadol abruptly. You need to introduce the drug below the amount the person was initially taking, and then gradually you will be reducing it until the person now can go off it without the withdrawal symptoms. So withdrawal occurs is when you have a decreased amount of what we call the substance the person has been on in the blood. Then we have codependency. Now, codependency is also when you have an individual who abuses drug or abuses a certain form of substance, getting what we call the significant other to do things that in one way or the other will encourage the abuser to still abusing the drug. So this time around, the significant other is being termed as being codependent. So let's say you are married to someone and the person always abuses alcohol. And because of her alcohol abuse, the person always get issues and then the person always get arrested. You know, when they arrest the person, anytime they arrest the person, you go and bail the person out. When the person comes out, the person continues to misbehave. Or let's say, whenever the person, and because of drug abuse, the person is failing to take responsibility, taking care of maybe the family, paying school fees and other, bills. And because of that, you, the spouse, have set or have taken those responsibilities on yourself to be paying the bills, to be taking care of the family. And that alone is also encouraging the person to continue the drug use and then misbehaving. And so when that happens, you, the significant other, you are termed as being codependent. So codependency issue or codependency is where the presence of a coexisting behavior present in what we call the significant other, which serves to enable the addict or the alcoholic to continue the irresponsible pattern of use without experiencing consequences. So I have an example here. Example is that, example of a codependency is paying bills for which the addict or the alcoholic is, responsible. Bailing the addict or the alcoholic out of bail, and then helping the addict or the alcoholic to call in sick to, employment agency. So this one is where, let's say, you have an abuser who goes to drink alcohol, comes back, the person is drunk, the next day the person has to go to work, and then because of hangover or because the person, hasn't fully recovered from the substance use, you pick a phone and call the person's workplace and tell the person and tell the HR that my husband cannot come to work or my wife cannot come to work because my wife is sick. And a normal circumstance, my wife is not sick. It's because of the abuse, or it's because of the alcohol the person has gone to take. That is what is making the person not to be able to go to work. And you end up lying. And that lies that you lie will help the abuser or the person using the drug to continue to use. Because at the end of the day, he or she knows that when he comes home, you are going to assume those responsibilities, or you are going to help him to continue what we call the drug use. And so you, the one who is doing that, you, the significant other, you are the codependent, or you are the codependency. And so the codependency, him or herself does not engage directly in the drinking of what we call the alcohol, or engaging in the substance use, but engages in what we call certain activities that promote or that encourages what we call the abuser to continue to abuse the substance. And so that is what codependency is about. Now, let me stay on codependency and talk about manipulation. Now, I've said that codependency is where the significant other is doing things to help what we call the abuser to continue to abuse the drug. Manipulation is the same as codependency, with the exception that manipulation always results in what we call the significant other engaging in illegal activity. And so when the significant other is engaging in illegal activity, it is no more what we call codependency. It is now manipulation. So let me use this example. Let's say a father sends an 8-year-old boy to go and buy what we call alcohol for the father to take. Now, this is manipulation. Why is it manipulation? It is manipulation because the significant other, which is the son, is 8-year-old, and an 8-year-old, according to law, is not responsible, or is not legally cannot go and buy alcohol. Okay, cannot go and buy alcohol, because if the 8-year-old goes to buy the alcohol, the person is not at the legal age to be able to go and buy alcohol. And so in that manner, it is still manipulation, or it is codependence, but this time around, we term that as what we call manipulation, because the significant other is engaging in activities that are illegal. If it was to be someone, let's say the same example, but rather the son is, let's say, 21 years or is 18 years, that is not manipulation, because after 18 years, the person is now legally, is at the legal age to be able to go and buy what we call alcohol. So we will tell that to be what we call codependence. And so manipulation is when the significant other engages in activities that are illegal and then encourages or promotes what we call the abuser, or the one who uses the drug to continue to use the drug. So when you get a question on what we call either it is codependency or manipulation, look at the activity that is ongoing, or look at the activity the significant other is engaging in. And then if it is illegal, then it becomes manipulation. But if it is legal, then it is what we call codependency. Now, when it comes to codependency issue, it is important that you address codependency issues with the family to maximize the chances of recovery of the client with the addiction, and then the person with what we call the codependent behaviors. Yeah, so when it comes to codependency, we need to talk about it with what we call the family, so that the family will come in, because if you don't tackle the codependency alone is promoting the person to continue to use the substance. So at the end of the day, the person might not recover. So you need to tackle codependency, talk about it, let the person know that if he or she continues to engage in the codependency behavior, it is going to encourage the abuser to continue to abuse the drug, and the person is not going to quit or is not going to recover. So that is it. So that is on certain, terms we need to understand how to go about them and explain them. And then we talk about alcohol. So let's now dive into alcohol. Let's look at alcohol withdrawal. We'll look at alcohol withdrawal in terms of the neuron frameworks. Alcohol is a central nervous system depressant. Like I said, it's a downer. Okay, alcohol is a downer. It's part of the downer family of drugs that we term them as downers. Downers are central nervous system depressants. So they depress your central nervous system. So that means that if you get intoxicated on alcohol, your central nervous system is going to depress. And when you get central nervous system depression, it is as if like almost everything in your system is going down. And so in alcohol abuse or intoxication, we look at hypotension, we look at bradycardia, we look at low body temperature, we look at bradypnea, and almost everything like in your system going down or shutting down. So that is, I've always said that when it comes to downers and uppers, you don't chew assessment findings here. Understand what the substance does. If it is a stimulant, or if it is a downer, downers will suppress you, or downers will make things to go down. So you now pick your pen. What are some of the things that when you are going down, it will happen? So when you are going down, you know that you become more drowsy. You know that, in terms of heart rate will go down. In terms of respiratory rate, it will go down. In terms of temperature, it will go down. So you start writing them down. And at the end of the day, you look at your options, you can come out with what you call the possible answers to that very question. If they are asking about findings for, let's say, intoxication on a downer, or a downer like alcohol. So that, the physical dependency is a biological need for the individual to avoid what we call withdrawal symptoms, whereas the psychological dependency results in craving for, the subjective effects of what we call alcohol. So because the individual wants to avoid withdrawal, the physical withdrawal symptoms, the person continues to take, because the moment the person goes off from what we call the alcohol for a certain number of hours, or a certain number of hours, the person starts to experience withdrawal symptoms. So because of that, the person will always want to take the drug so as to prevent what we call withdrawal from happening. When it comes to the risk factors for what you call alcohol intake or alcohol use disorder, we have numerous. It could be ranges from family to certain psychological issues like depression, when one is anxious, low self-esteem, poor self-control. History of bad behaviors like poor school performance and then delinquencies, and then poor parental relationships. These are all risk factors for what we call alcohol use disorder. Now, like I said, when someone abuses alcohol or uses alcohol and it becomes intoxicated, alcohol is a central nervous system depressant, which is a downer. So we are looking at assessment findings related to coming down. So there's slurred speech, there is uncoordinated movement, unsteady gait. We know this, okay? We've all seen people who have taken alcohol and then they are intoxicated on it. You see the movement become very difficult, restlessness, confusion sets in, and then they tend to sneaking, drinking in the morning and experience what we call blackouts. Binge drinking. So binge drinking is where the individual continues the use of the drug. This brings me here. The last time, did we talk about what's it? eating disorders. This brings me back to when I saw the binge drinking. Did we talk about eating disorders? Hello.
No,
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 sir,
no.
we didn't.
We
Comment.
talked about eating disorders.
No, we
Okay.
didn't.
Day to day.
All right. I think I should have done that. I thought I've done that too. But it's not actually part of this very but let's finish. I'll have to go back and do the eating disorder. It's very important we do eating disorders. At least we need to do the eating disorder. I thought I've done eating disorders. All right, so that is fine. You let's continue with this. When we are done, we'll go back and do the eating disorders. I thought I've done that. So binge drinking, where the person continues to use, drink the drink the alcohol, like when you take like bulimia nervosa, where the person will continue, binge behaviors. The person eats a lot, and at the end of the day, will have to find a way to compensate for that by taking substances that will help the person to bring out whatever they do. So there's binge drinking. They tend to arguments about drinking. They tend to miss work. Like I was using the codependency issue as an example. So they go and drink, come back, hangover, they cannot go to work. So they always missing work. Increase tolerance to what we call alcohol. They will continue to use what we call the alcohol, or continue to increase the amount of the alcohol intake in order to get the desired effect based on which they take the alcohol. And for intoxication, for one to be said to be intoxicated in the US, if one is intoxicated and probably the person is admitted, they would have to pick sample of the individual's blood in order to check the content or the amount of alcohol the person has taken. And so if they take your blood and then the alcohol content is 0.1% or 100 milligram of alcohol per deciliter of blood, then we are said to be such an individual is said to be intoxicated. This value, when you go to the various states in the US, each of them might have their the amount or the percentage in your blood for you to be said to be intoxicated. But this is generally why we should know that they pick your sample and then they go and check, and you've taken about 100 milligram, or when they check and then they're able to pick more than 100 milligram or 100 milligram of alcohol in your blood, then it means that you have intoxicated. So this will apply to, let's say, someone who is intoxicated and is driving, and they catch the person. They take the person to the law court, and they will have to check the amount of alcohol the person has taken on in the blood. Then this is where that will imply. Now, when it comes to the physiological, the psychological symptoms the person will be showing when someone is intoxicated on alcohol, depression could be there. They become a bit more irritable and then hostile as well. Suspiciousness, they tend to use rationalization as a form of compensation. Some of them, alcohol people or people who abuse alcohol too are mostly denial. They also tend to have denial. They don't want you to talk about the alcohol use. And the moment you start talking about the alcohol use, they would argue that they don't take alcohol. And so they tend to use what we call denials a lot as well. Isolation is also there. Decrease in inhibitions, and then self-esteem also decrease. They tend to use denial. So denial that the problem exists. So they will never agree with you that their intake of what we call alcohol has resulted in problems, and they wouldn't accept that, and always tend to use what we call denial to defend themselves. Now, when it comes to complications of alcohol use, that is chronic alcohol use, we know, especially those of us, the medical experts talk about anemia, talk about the liver issues, hepatitis, talk about cardiac problems. People tend to have hypertension, and later it could result in heart failures and all that. So cardiac problems, and then they also tend to develop immune system disorder where their immunity suppressed, or they get suppressed immunity, and they are not able to fight against infection. There is anemia, there's pancreatitis, and then what you call gastritis or abdominal issues, as well as hepatitis, liver cirrhosis, very common among alcoholics, right? So then the next important thing I want to talk about is the effect of chronic alcohol use on vitamins. And so that is vitamin deficiency, specifically vitamin B deficiency, resulting in peripheral neuropathies. And so peripheral neuropathy, where the person tends to develop nerve issues. Okay. Peripheral neuropathies as a result of vitamin B deficiency. And then they also have thiamine. I hope thiamine is vitamin B1. Am I right? So thiamine deficiency, which is vitamin B1 deficiency, resulting in Korsakoff's syndrome or Wernicke's encephalopathy. And so Wernicke's encephalopathy was, Korsakoff syndrome is one of the things that at least we need to know that it's one of the complaints. So they ask, you know how I believe you might have come across such questions, but they will ask you that someone on alcohol use or someone who might have used alcohol for a very long time, which are the possible complications the person is expected to use, and they want to relate it to the kind of vitamin that is affected. And so you should be able to know that when one takes alcohol for a very long time or chronic use of alcohol will result in what we call vitamin B1 deficiency or absorption of vitamin B1. Okay. And so that will later result in thiamine deficiency and as a result causing the Wernicke's encephalopathy, where it leads to psychosis, certain form of confusions and abnormal eye movement. And so all that I just want us to understand is that the alcohol use leads to thiamine deficiency, and a thiamine deficiency will result in the Wernicke's encephalopathy. This is what the English will want you to know. And if you know this, you are good to go. So these are some of the possible complications with what we call chronic use of alcohol, or when someone uses alcohol for a very long time. These are the problems the person is likely going to experience. Then we come on to what we call withdrawal. When an individual is withdrawing from alcohol, what are some of the things we have to know? So here too, let's bring our uppers and downers here. I said that alcohol is a central nervous system depressant, which is a downer. And if you abuse a downer or if you are intoxicated on a downer, it will let you go down. Now, when you are withdrawing, withdrawal means that you have a little amount of the drug in your blood. And as a result, it causes you to go up. So when you are withdrawing from a downer, you tend to experience upper symptoms, or you tend to experience symptoms related to the central nervous system stimulation. And so withdrawal is when there is an abrupt cessation of alcohol use resulting in central nervous system overactivity. Overactivity means stimulation. So when you cease the alcohol intake abruptly, or someone who has chronically used, not like someone who just one day just go and take it. You know, those who abuse alcohol all the time, you see them at what you call the drinking spots. All the time they are there. The moment they go out from it for a certain number of hours, then the person tends to, misbehave, start to, experience withdrawal symptoms. So the cessation leads to central nervous system overactivation or overactivity. Early symptoms develops within few hours after cessation of alcohol. However, these symptoms peak after 24 to 48 hours and then rapidly decline unless it progresses to what we call alcohol withdrawal delirium. And so within few hours after the person has ceased the alcohol intake, the person starts to experience central nervous system overactivity. And then within the symptoms peaked. I believe when I say peaked, you understand, like the symptoms become more, intense within 24 to 48 hours. And then if the person gets the needed treatment or the needed support, the symptoms will disappear. However, if the support is not there or the person is not treated and it goes beyond 48 hours, the person goes into what we call withdrawal delirium tremens or withdrawal delirium. If the withdrawal is not treated, severe and life-threatening symptoms may occur, which will include seizures and then tremors. Okay, so that is where, if the withdrawal is not treated, severe and life-threatening symptoms may occur, which will include tremors and then seizures. So tremors where the individual, extremities will be shaking, and then seizure, general body shaking. And I believe we know seizures. So this is not a time to come and explain what happens in seizures. Okay. So if it results in withdrawal and the person is not treated, that is where it leads into tremors or delirium tremors, and the person trying to experience life-threatening symptoms like seizures and then delirium tremors. Now, I said withdrawal means that the central nervous system overactivation. So let's think about everything in the system is going up. So there's hypertension, there's tachycardia, there's just think, don't chew these things. Sit down and then start asking yourself what happens when everything in your system is going up. Okay. So there's nausea, there's vomiting, there's tremors, especially in the hands, sweating, and then anxiety, agitation. The person tends to hallucinate. So they tend to have tactile hallucination, auditory hallucination, visual hallucination. Very common with these people. And then, so in tactile hallucination, the person will be complaining of itching, experiencing certain pins and needle sensation, burning, numbness, and feeling of sudden, bags clawing on what we call the skin. They tend to have the auditory hallucination where the individual will be telling them, I'm hearing voices commanding me to do certain things. Okay. Then they have what we call visual disturbance. The person will tell you that they tend to have photosensitivity, and then visual hallucinations will also be occurring. They tend to have headache. Disorientation is also very common with them. So that is on withdrawal in terms of findings related to alcohol withdrawal, what we should expect with regards to alcohol withdrawal. Now, that is on withdrawal. Now, let's look at delirium tremors. Now, we already know delirium, right? That there is that, issue with memory. Okay. When I think I was supposed to continue to that, I was supposed to continue. Now I was supposed to continue with the Alzheimer's disease. Okay, I was supposed to continue with dementia related problems. I think I that is where I was supposed to start from. So that makes me. So after this, I have to go back. And so you need to understand that delirium itself is when you have temporal memory disturbances, mostly as a result of physiological problems. It could be as a result of tough substance use, it could be as a result of infection, it could be as a result of, let's say, dehydration and all those things. It could lead to certain form of confusion, forgetfulness and all that. However, if someone is taking alcohol and the person is withdrawing from alcohol and the withdrawal exceeds 48 hours, the problem now becomes what we call delirium tremors. So delirium tremors is a state of delirium, usually peaks 48 to 72 hours after cessation or reduction of what we call reduction of intake, although it can occur later and last for 2 to 3 days. Now, this is where I want us to take note of the hours within which delirium tremors happens. Delirium tremors happens after 48 hours of cessation of what I call alcohol. So the person takes alcohol, or the person is a chronic alcohol user. The person today the person hasn't taken the alcohol, and then it continues for more than 48 hours. After 48 hours, it is no more withdrawal. It is now turned to be what? Withdrawal delirium tremors, because it is more than 48 hours. And now the symptoms are more intense or are more severe. And so this time around, the person's symptoms, the person will be shown. The symptoms are virtually the same as withdrawing from what we call alcohol withdrawal symptoms. But this time around, the symptoms are more intense and more severe. So if it is hallucination, the hallucination becomes this time the person, if it is auditory hallucination, that is where the person will be telling you the command things are there. They are telling me to harm someone. If you don't take care, the person will end up harming someone. They become more agitated. So agitation increases here. They tend to complain of anorexia, anxiety, delirium, where they have those kind of confusion. And then the diaphoresis, that is the sweating, becomes more intense. And then we tend to have what we call disorientation with fluctuating level of consciousness. Fever is also there. So they tend to have increased body temperature. So mostly that will be between 100 to 103 Fahrenheit. We have hallucination delusions, which are the insomnia, tachycardia, hypertension. Just like I said, the symptoms are like the same as what we call, withdrawal. But the differentiating factor is what? Is the time duration at which it is occurring. And the symptoms also during delirium tremors are intense, are severe, okay, as compared to that of just withdrawal symptoms. They will ask you about it, and so you need to understand. You need to understand the time duration, and it's the time duration that will help you to distinguish or to know that the person is experiencing what you call delirium tremors. When it comes to alcohol use interventions, you need to administer prescribed medication to help the client. And then let me stay on medication. This reminds me. Now, when it comes to alcohol use in terms of medication, let's say someone is experiencing withdrawal and you need to give medication. The two most common medications, or the medication that when it comes to alcohol, we use the benzodiazepines, okay? Because during withdrawal, the person becomes agitated, seizures and all that also setting. So you need something to calm the person down. So you need your benzodiazepines, either your diazepam or whatever palm you are given. And then we have cladioposides. Cladioposide is the same as Liberum. Let me stay on Liberum. Now I'm using Liberum because in the NCLEX they will always give you cladioposides and then into bracket Liberum will be there. So it is good you know cladioposide so that you don't see Liberum. You know that cladioposide is what I'm talking about, because cladioposide is a generic name. Liberum is the trade name. And you know that different companies might have what we call their name for. But for the NCLEX, if they are using cladioposide, they will always bring what we call Liberum. Now, during active withdrawal syndrome or withdrawal symptoms, we give what we call Liberum together with probably your benzodiazepines. I'm saying this because you will get a question where they will tell you that someone has stayed off alcohol and is experiencing alcohol withdrawal. Which drug do you anticipate the healthcare provider to give? And you have Liberum there, and you have Antabuse there, okay, or Disopherium. Antabuse is the same as Disopherium. Now, these two drugs, we need to, especially with Disopherium, what to avoid when you are taking Disopherium, what to avoid when taking Disopherium. All right, someone is saying I'll put the drugs names on the screen. Okay, I'll write them for you. So you need to understand the use of. Let me finish. I'll do that for you. You need to understand, or if someone can put it on the comment chat for us. Okay, someone should do that. Put cladioposide. I believe we know that. So if you know cladioposide, put it on or Liberal. Put it in the comment section for us. Okay, and then Disopherium. So I've finished talking about cladioposide. All that we need to know about Liberum or cladioposide is that it is the drug to use when someone is actively experiencing delirium tremors. And so if you are experiencing delirium tremors, what we did as a nurse, you expect the healthcare provider to give is Liberum, not Disopherium. Now, Disopherium or Antabuse is an option for someone that wants to stop alcohol use. It's for someone, so we say that it is used as an aversion or as aversion therapy. It is used as an aversion therapy, means that you want to avert the person's alcohol use. You want to stop the person's alcohol use. So let's say you have a brother or you have a family member who abuses alcohol. You want to take that person to a camp, or you want to send the person somewhere. And as you are going, you don't want the person to continue the use of the alcohol. The person cannot stop. Is struggling to stop the alcohol use. However, you want to go with the person and you want the person to stop using the alcohol. So in that instance, you discuss with your healthcare provider, and the healthcare provider goes in for what we call Disopherium or Antabuse. Now, when it comes to Antabuse use, before you can use Antabuse, you have to stay off alcohol for at least 2 weeks. So before you start the medication, you have to stay off alcohol for 2 weeks before the medication will be started. And so let's say you want to start using the for someone. Before the person can start the medication, the person might have or should have stayed off alcohol, anything containing alcohol for 2 weeks before the medication can be started. Then, the person starts the medication 2 weeks after the person has stayed off the medication, the alcohol. Person continues for, what number of days or those the healthcare provider want to use. Now, before the person goes back to alcohol, before the person go back to alcohol, the person should also stay off for after the last dose of alcohol. The person can be allowed to go near alcohol 2 weeks after the last dose. So you stay off alcohol 2 weeks before you start. When you stop it, you can only allow to go near alcohol again 2 weeks after you have stopped what you call the alcohol. Now, what are some of the things we need to do when taking the We need to avoid everything containing alcohol containing product. And so in the enclaves, they will always ask you, or in the queue banks, they always bring hand sanitizer, mouthwash, and those things that we use in our homes that contains what we call alcohol. Any product that contains alcohol. These are the 2 examples that comes mind off head. Mouthwash and then hand sanitizer. Those are the common substances that are used in our homes. And so the time you are taking what we call the alcohol, so within the time you are taking the medication, which is the disulfiram, you are not allowed to use any substance that contains even 1% of alcohol. You are not allowed to use, like mouthwash and hand sanitizer, because when you use it together with disulfiram, you are going to encounter serious complications. So that is why the person needs to observe those protocols whilst on the medication. Yes, there's a hand up, Mr. Kabir, your hand is up.
But Amingo,
Yeah.
please, within these 2 week period, when the patient run into what's the name? Withdrawal.
I said 2 weeks before you start the medication. 2 weeks. And so that means that you might have managed the person in terms of alcohol use. Okay, 2 weeks. So within the 2 weeks, the person is not going to experience withdrawal. That is not going to happen. Okay. Yes, it's not going to happen within the 2 weeks. So as the person takes the medication, the person will not have like appetite for alcohol. That is what I want you to understand. Okay. Whilst on disulfiram or antibutyl, you are not going to have that kind of appetite to even go near alcohol. But the moment you stop, you might want to go back again. Okay. So it's actually used. That's why I was giving an example that, let's say you are going somewhere and you don't want to take alcohol. Probably if you take alcohol, it's going to disgrace you. Okay. And so you want to stop the alcohol. And so that is the period in which you need to take what we call the disulfiram, so that you will not have the desire to go in for the alcohol. All right. So I think someone kept the drugs there, the cardioposides, and then antibutyl is there. All right. Thank you, the one who kept it there. We have you provide care in a non-judgmental manner. Check the clients frequently. You monitor signs related to vital signs. We've talked about it, that hypertension, tachycardia, and then its related issues in terms of withdrawal and then alcohol intoxication. So you need to monitor vitals, neuro assessment every 15 minutes, provide one-to-one supervision. You need to monitor electrolytes, especially glucose intake. Glucose, one symptom that can mimic what we call hypoglycemia is when one is intoxicated on alcohol. When you are intoxicated on alcohol, you might start to experience symptoms related to probably what we call hypoglycemia. So you need to, when the person comes and you are monitoring the person, you need to monitor what you call glucose to know that it is not the alcohol or it is not hypoglycemic reaction the person is experiencing, and it is rather the alcohol the person might have abused. So you need to monitor electrolytes, glucose, you need to monitor magnesium. You nurse the person in a non-stimulating environment, okay? Encourage family members one at a time and then to stay with the client to minimize anxiety. You frequently have to arrange your clients, explain procedure and everything in much more quiet and then simple manner for your client. Because these people, we said that they are more at risk for what we call seizures, especially when they are withdrawing. So you need to initiate your seizure precautions. You need to make sure you are nursing the client on a low bed. You need to make sure that you have your resuscitation equipment on the bedside. You have your suction machine on the bedside. If you need to use them, so seizure precautions need to be implemented. You have to give your clients small, frequent, high carbohydrate foods. You might need to administer antiemetics because of the nausea-related issues. And so monitor intake and output, very important. And then you assess your clients with activities of daily living, and then allow them to also express their concerns as much as possible to you. That is on alcohol use, okay? If you have any question you want to bring it on board, you can add it. So if you have any input, anything at all you want to add based on what I've said, related to alcohol use, related to anything you want to bring on board, you can bring it up for us to discuss or related to alcohol or what I've said. If I'm not able to do that, I believe other people who might have come across it can equally help us to also go through. So someone is asking, please, can you go through SIGWA's core key for access? And I didn't prepare for that, so I might not be able to do it now for you because so probably if the one asking the question also has any fair idea on it, or anyone has a fair idea on SIGWA's core to, the person can bring it up. As I said, I didn't prepare, or I haven't prepared on it, so it might be very difficult for me to talk about it very well for you. And so if it wouldn't worry you, probably we'll have to, prepare on it and then come and talk about it. But for today, I might not be able to talk on that. Yes, so let's do the other. So let's look at someone dealing with a client who uses substance. So if you are dealing with someone who uses substance, it directs the client's focus on the substance use disorder. So you need to let the client understand, the problems related to the use of what we call the alcohol. You identify situations that precipitate anger feelings with the client. So you need to, assess your clients, know what is actually causing the client to probably become, more angry. And then you set limits. These people, you need to set limits, especially on those with manipulative behaviors, verbal and then physical abuse. Hold the clients firmly accountable to, reasonable limits, and then you consistently reinforce rules, and then reasonable consequences for breaking rules. So you need to, those with those abnormal behaviors, those with the antisocial behaviors as a result of use of substances. So you need to set your rules. Then you need to be firm on your rules as well too. You hold the clients accountable for all behaviors. So if they take alcohol and they are misbehaving, let the clients face the consequences. Let the clients be accountable for all the behaviors that they are exhibiting as a result of their alcohol use. You need to use motivational interview to assess the client, to explore strengths and then what you call them weaknesses. You have to encourage the client to focus their strengths. If the client is losing control, so you need to help the client identify their strengths, focus more on their strength than what we call their weaknesses. Encourage them to participate in group therapy. In fact, when it comes to alcohol, group therapy is one of the important things that you need to understand that it is important, especially we bring that alcohol is it anonymous group, alcohol anonymous group that the person has to join. Joining the group will help the person to learn about how other people are taking to learn about their symptoms, okay, and then how they are managing their use of alcohol and how they are becoming productive and all that. So the clients need to understand that group therapy and support groups are very, very important here. Someone was asking if I talk about delirium tremors. There is no special treatment for delirium tremors. Like I said that when someone is withdrawing, what you give medication, I talk about radiopulsar Librium, I talk about the use of what we call the benzodiazepines to calm the person down. Depends on the symptoms. So the delirium is not something that we say that I'm tackling delirium. Delirium is about confusion. If you manage the person, whatever is causing the problem, you take it off. And the person confusion or level of consciousness becomes fine. And so all the symptoms, it is the symptoms you are going to manage. So if it is hypertension, if it is high body temperature, you manage the high body temperature. And probably your cooling blankets and other things you can do to assist the client. And then seizure precautions are very key when someone is experiencing delirium tremors and all that. And so it is not like specific interventions for managing what we call delirium. I mean, you need to tackle the underlying cause of the delirium. Even if it's delirium in general, if it is infection, you treat the infection, and then the person level of consciousness will be attained after the problem causing what we call the delirium has been resolved. Okay. Now let's look at the APEDs and then let's look into the other drugs. Okay, so the other drugs I've talked about alcohol. So I went through alcohol very extensively. Now let's look at other downers. Okay, so the other downers are benzodiazepines, so central nervous system, benzodiazepines, barbiturates, and then anti-actors, depressants. They are some are sedative, they are hypnotics. So these alcohol, benzodiazepines, barbiturates, when you take them, it will make you go down. Okay. And now overdose on these things produces cardiovascular or respiratory depression, coma, shock, seizure, and death. And so if you look at downers, okay, so another downer, I think I should have included the opiates. I'll talk about opiates. So opiates also falls under downers, okay. So when we talk about the opiates, you get to understand that opiates also falls under downers. They are central nervous system depressant. So these central nervous system depressants, overdose of them, if the client is awake, vomiting, when you want to treat it, when you want to treat overdose on, I mean, let's say alcohol, or let's say someone has abused or has taken excess of a downer, you want to treat it, you give vomiting will be induced using activated charcoal, and then the person brings up everything. If the person is comatose, you know that, or the person is in coma, you can't induce vomiting because of likelihood the person is going to experience aspiration. So you might have to use what we call gastric lavage, and then you maintain the airway. They will do gastric lavage and then with an activated charcoal, and that will help remove the excess of the drug from the person. Seizure precautions need to be initiated as well. Flumazenol, we all know. If you don't know flumazenol, you know that flumazenol is given intravenously specifically for people who might have overdosed what we call benzodiazepine. So when you look at it's an antidote, so we know that we have various drugs and their antidote. We have some drugs and their antidotes, like heparin, like melatonin, like warfarin, and all those things. So the same thing when someone takes in benzodiazepine, or someone has taken benzodiazepine, excess amount of it, and the person has become too drowsy, difficult to arouse the person, and then respiratory depression and all those things are happening, you might have to give flumazenol. So flumazenol or flumazenil, flumazenil is given intravenously as an antidote. So we need to know what that very drug is used for. It's an antidote to reverse the effect of what we call benzodiazepine use. The withdrawal must also be treated carefully by titrating the similar drug. So that's why I was saying that if someone is taking drug and then you want, or the person is withdrawing and you want to treat the withdrawal, what do we do? You might have to introduce the drug the person was withdrawing from, small quantity, okay, until the person becomes okay. Because the withdrawal is happening because the person has small amount of what we call the drug in the system. So when you introduce the drug into the system, small amount, or you titrate it, okay. Or if someone has been abusing, let's say, some of these drugs and you want to treat it, you might have to be introducing the drug small. You might have to be titrating it small before you can take the client off from what we call the drug. This is to prevent abrupt withdrawal that can lead to death. Withdrawals from what we call central nervous system, such as barbiturates, will generally be treated with barbiturates such as phenobarbital or long-acting benzodiazepine. So if someone is withdrawing from the central nervous system, that is why I was saying that even in alcohol, we give what we call the benzodiazepines to help control the symptoms and all that. So generally with downers or central nervous system depressant, if the person is intoxicated, I said, don't go and chill the symptoms. Look at what is happening to the person, write your symptoms down, you are good to go. So intoxicated on a downer will lead to hypotension, will lead to drowsiness, will lead to impaired memory, attention issues, judgments, steady gait and irritability, less speech and all that. And then if you are also withdrawing from a downer, like we just did in alcohol, you know that everything is going to go up. So there's nausea, vomiting, tachycardia, diaphoresis, anxiety, irritability, tremors, and then things that indicate that things are going up in the individual, or things are going to show up in the individual. So these are for what we call downers, or these are for central nervous system depressants. Now let's look at what you call the stimulants. These are not all the stimulants. The other, I'll also talk about the other ones like LCD. Okay, I always don't want to mention the full because of how difficult it tends to pronounce some of these words. But when you get there, you get to understand them. So central nervous system stimulant, or APES, will also cause you to go up when you are intoxicated on them. And so we have amphetamines, we have cocaine, we have crack. I think the crack and the cocaine, they are all related, okay? If you have talked to those people who have used cocaine, they'll tell you the crack, how the crack also looks like. So the cracks are also part of what we call the cocaine families, or how the cocaine will make you behave. So when someone takes cocaine and the person get high, see what the person tends to become. Person get high, everything goes down. So overdose on a stimulant will cause respiratory distress, ataxia, hyperparesia, seizures, coma, stroke, myocardial infarctions, and then that can also occur. If you want to treat what we call an overdose on stimulants, you might need to use antipsychotics and then management of associated effects. So you actually manage what we call the symptoms. You give what we call your antipsychotics as well to help manage. Okay, coffee. So coffee is also a stimulant, right? Yes. So if someone takes coffee, that is why people take to learn. Okay, when people tell you that when I take coffee, I can stay off, I can stay throughout the whole night, and then I will not feel sleepy. So caffeine or coffee is also part of what we call the apex, or the stimulant. Withdrawal is also treated with antidepressants, which is dopamine. And so when someone is withdrawing from a stimulant, you see that the person will become more sober, like someone who is having depression. And so in that instance, you might have to give antidepressants, which is a dopamine agonist, to help the client to become a little bit high. And so the person will now tend to become happy and then be more engaging. Bromocriptine is also, use in managing what we call withdrawal symptoms related to drug use. So withdrawal is primarily supportive, particularly when dealing with severe depressions and suicidal ideations that accompanies what we call stimulant withdrawal. Now let's now look at, uppers or stimulants in terms of the symptoms the person will be showing. So with stimulant or with uppers, you have what we call if the person is on upper and is intoxicated or taking excess of it, everything in the system goes up. So there's dilated pupils, the eye will become more open, they become more euphoric. So that is why someone takes cocaine and the person thinks like he's the Oga. Everybody thinks like, this guy is like Oga. So there's that kind of like euphoria, and then, physiologically, the heart rate will go up, blood pressure will also go up. So there's hypertension, tachycardia, impaired judgment, insomnia. So that's where she was talking about coffee. That when someone takes coffee for a very long time, the person will tell you that I don't even sleep. I'm not able to sleep at night. And so we have insomnia, which can occur. They tend to hallucinate. They have paranoid symptoms, and then delusions can all occur. Agitation, cardiac dysrhythmias can occur. Then if you are withdrawing from an upper, you go down. If you are withdrawing from upper, you go down. So everything goes down. There is fatigue. Insomnia can equally happen. You tend to have hypersomnia. So mostly the problem will be more of hypersomnia, where the person will be sleeping more. So this time around, the person will be sleeping more. Then we have anxiety, agitation might happen. They tend to become more depressed. And we know that depression is associated more with what we call suicidal ideations or suicidal thoughts. Then opiates, I said that opiates are part of downers. Opiates are downers, right? And so when you take what we call tramadol, for those who might have taken tramadol before, and then, or we might have seen people who abuse tramadol. Currently, we have something in Ghana they call one, what's the name? Red. Yes, red is high dose of tramadol that people are abusing. And so you know that when they take the alcohol, when they take what we call the opiate, they become more like junkies. Okay, you see them like the junkie kind of people. Okay, so opiates generally are part of what we call downers. The opiates such as opium, heroin, paradine, morphine, codeine, and then methadone, hydromorphone, and all those things. They are downers. Overdose will produce respiratory depression. So that is why when someone is taking opioid, one of the things you need to watch out for is respiratory depression. The moment the individual tends to have respiratory depression, it means that the person might have taken excess of what we call the medication, leading to the respiratory depression. It can equally lead to shock, coma, seizures, and death. Withdrawal should be performed using what we call evidence-based tools like the clinical opioid withdrawal use. The same thing. I would generally not go into the post or the clinical opioid withdrawal skill, but I just want us to understand that if someone is withdrawing from what we call opiates and we want to assess, we use, the best tool to use is what we call clinical opioids withdrawal skill. Opiates are downers. So I said that opiates are downers. So when you are intoxicated on opiates, you have everything in your system going down. So they have constricted pupils. You remember when we were doing the stimulants, we said that it will call dilated pupils. So if you are intoxicated on a downer, which is opiate, you have what we call constricted pupils. You have bradypnea, you have drowsiness, hypotension, everything going down, and then everything going up when you are withdrawing from opioids. We have tachycardia, diaphoresis, restlessness, dilated pupils, and then body aches. They tend to have rhinorrhea, like cremations, and then diarrhea, vomiting can all occur when one is withdrawing from what we call opioid use. Then the hallucinogen. So that is what I was talking about. LSD. That is a lysergic acid diethylamide, right? So it's one of the common ones you use in the NCLEX. It's very common. This very upper. It's very common in the NCLEX. And I think PCP is also quite common. That is phenylcyclinide, or how do you pronounce it? Phenylcyclinide, right? PCP. Always know that when they write the drug, they will always put this the abbreviations on it for you to know. Okay, so hallucinogens are APEs. They are also part of APEs. They include LSD. They include mescaline. And then the mushroom name is also there. I don't want to mention that. Okay, then we have PCP, which is also part of, the hallucinogens. They are all part of APEs. So the hallucinogens also part of APEs. If the person is intoxicated or overdose of these substances, if an overdose of these substances occurs, they tend to have serious health issues as a result. Okay, overdose of what we call them, overdose effect of LSD, peyotes, and then I don't want to pronounce them. We include psychosis, brain damages, and then overdose of PCP is more of psychosis. So you see that the overdose of PCP, they have separated that from the overdose of the other three. And so we need to know sometimes there are questions more specific to PCP as to what symptoms someone abusing PCP or someone who overdosed PCP will show. So PCP will include psychosis, hypertensive crisis. They will tend to have hyperthermia, seizures, and respiratory arrest can happen. They are APEs. So if you overabuse these things, you tend to exhibit APA symptoms. Treating or treatments with the first three will involve nursing the client in a low environmental stimuli, speak slowly to the client and in a low voice. Medication to also treat anxiety could also be there. And then with PCP, mostly you might have to do what we call gastric lavage if the person is alert, and then treatments help acidify the urine to assist in excreting the drug, and then interventions to also treat the behavioral issues, hyperthermia, hypertension, respiratory arrest. I mean, these are more supportive treatments to help, manage symptoms specifically. Management of withdrawal is primarily supportive, which may include medication to target the specific problem the person is experiencing. If it is agitation, you might have to target agitation and manage it. Some tend to have what we call flashbacks. So especially if they take hallucinogens, they tend to have what we call flashbacks of unexpected re-experiencing of the effect of the hallucinogen drugs, and can occur for extended period of time after the original drug use. So during the time where the person is experiencing flashbacks as a result of the use of hallucinogen, the most important thing to ensure is client safety. And so hallucinogens, I said that they are APEs. And so these are the upper symptoms when someone is overdosed or intoxicated, and then the withdrawal symptoms when someone is withdrawing from an upper, like hallucinogens. So we have intoxication, agitation, everything going up with regards to the use of it. The person will be experiencing downing behaviors or downer symptoms, okay? Having a call which is distracting the flags, but let me finish and call the person. All right. So that is on hallucinogens and symptoms. Generally, if someone is withdrawing from any medication use or any drug use, you need to obtain information about the type of drug and the amount consumed. You need to assess vitals. You remove unnecessary objects from the client environment, those that becomes more agitative depending on which drug they might have used. So for safety, you might have to provide one-to-one supervision for your clients. You provide quiet, calm environment, non-stimulating environment, and then you maintain Client orientation, very, very important. You ensure safety by implementing seizure precautions, like I said. So mostly with withdrawal, the management is more towards what symptoms the client is showing or what behavior the client is showing. I mean, use security devices if necessary and as prescribed to help prevent the client from harming himself and others. You might have to provide physical needs. So physical needs in terms of food, fluid, meeting the physiological needs of the individual, assisting the person to meet activities of daily living, self-care, very important. Then you have to prescribe what we call medications to also help decrease withdrawal symptoms. You might need to take samples so that you do screening to know the amount of what we call the drug the person might have abused. And so that brings us to an end to uppers, downers, and symptoms to expect with regards to each of them. If I have left something out and then you remember what I've left out and you want to talk about it or you want to draw my attention to it, you can bring it up before we try to see if we can go through some few questions with regards to that. My class is quiet today, Papa. Ade, what for him?
So topic nation.
Shada,
I am a baby son.
every on.
Aye.
All right, don't worry. And yet,
It's not sweet.
sad. So that
And
is
the
all.
speed.
And the speed. All right. Sorry for that. Any input, any question? Okay. I have a question on my screen. What time frame after the last drink would a patient most likely begin to experience seizures during alcohol withdrawal? We have 6 to 8 hours. We have 12 to 24 hours. We have 12 to 48 hours. We have 3 or more days. Oh, yeah. Okay. I see people going for C. I see others going for D. All right. So we have C, which is 12 to 48 hours. Okay. That is when you really expect the person to experience seizures. That is the time duration. So seizures during alcohol withdrawal typically will occur between 12 to 48 hours after the last drink is taken, as symptoms can escalate over this period as well. So it is not 3 or more days. 3 or more days is more of delirium tremors. Okay, even that is past 72 hours, right? Even tremors, we said that it's 48 hours. That is 2 days. So 3 days or more means that you are more outside the time range.
Boss, please, can I see the question again, please? Please, so.
This was the question.
Hello, sir.
Yeah, kindly go ahead with your question.
Please, during the presentation, you said alcohol withdrawal starts from 24 hours to 48 hours.
I didn't say 24 hours. It's a few hours after the person has stopped taking the alcohol. It peaks at 24 to 48 hours. So get my words right.
Okay.
Thank you. All right.
Hello.
Yeah, hello, madam.
Yes. So thank you. That's my first time here.
All right.
So
You're welcome.
I think thank you. I've also read elsewhere that it's between 24 to 72 hours.
For withdrawal?
Yes.
No,
So what do we do?
72 hours, you have entered what we call
delirium.
Yes, it's delirium. 72
Okay.
hours delirium. Okay.
So specifically for withdrawal, between
less than 48.
less
So
than 40. Okay.
48 hours. Less than 48
12 to
hours.
36. 12 to 36, right?
Less than 48. So 48 coming down. 48 to 72. So between from 48 to 72 hours, it's where you expect delirium to set in, tremors to set in.
Okay. Thank you. It's a bit confusing anyway.
So delirium tremors is 48, mostly 48, 72 hours. Then withdrawal is less than 48 hours.
Okay.
So that's why when I was I said the time is where mostly get confused. Basically, that's where all of the questions you tend to get the time duration with you. I saw a hand up. Mr. Paul, your hand was up.
I was trying to say, even there were some good reports, even 3 hours after the last drink.
Yes, after the last intake, right? Yes, after the last intake, is that not the case?
Yes.
Yeah, so thank you, Mr. Paul, for your input. Already answering. Of course, this question is very simple. If you get such a question anywhere, and when I was trying to get questions for this, I was very struggling. So where I even pulled these questions from, I wasn't getting the actual Q banks to get this question. So, but I was able to manage this one. I wish I get a very good case study question on some of these things we have talked about, so we could run through. But let's see what we can do. So this very question is very straightforward. We are looking at a patient. You are managing someone experiencing alcohol withdrawal. What is the initial priority for the nurse to ensure patient safety? So the question is on safety, initial priority intervention for patient safety. We have vital signs, we have administering benzodiazepines, we have airway, breathing, circulation being stable, ensuring that they are stable, and then IV fluids. And I believe anyone here, even if it's your first time of coming across such a question, you know your ABC. So your ABC will always guide you to definitely probably go for the C. So that is it. So your C is your best answer to go at this point, to go from ensuring airway patency, ensuring breathing, and then circulations are all stable for this client. This is also quite simple. What are the potential consequences of untreated delirium tremors during alcohol withdrawal? This is really not simple. So we have severe dehydration, life-threatening complication, increased anxiety, mild hallucinations, which can also with mild hallucination. So the question is asking about which potential consequences of untreated delirium tremors. That can occur during alcohol withdrawal or potential consequences of untreated delirium tremors during alcohol withdrawal. Is it confusing? I think it's also straightforward. All right. So, be as you guys are going for. I believe we all understand that at this point, if you don't treat delirium tremors, you are likely going to experience some complications like seizures, cardiovascular issues, and death can even occur. So it's important that you have to manage the delirium tremors to help prevent the severe complications. This question says that a client with a history of substance abuse has been attending Alcoholics Anonymous meetings regularly in the psychiatric unit. One afternoon, a client tells them this: I am not going to those meetings anymore. I am not like the rest of those people. I am not a drunk. What is the most appropriate response? A says that you aren't an alcoholic. Why do you keep drinking? If you aren't an alcoholic, why do you keep drinking and ending up in the hospital? B is it is your decision. If you don't want to go, you don't have to. C, you seem upset about the meeting. D, you have to go to the meeting. It is part of your treatment plan. So we are looking at what to expect or what response from the nurse is most appropriate to give. Madam Mary.
Okay, thank you very much. With the question, the number one, A is not appropriate because they even say we should stop asking the client why. Then number two, it is your decision. If you don't want to go, you don't have to know. It's not also appropriate. Then number three, you seem upset about the meeting. I think this one is more therapeutic than the A and B. Then the number D is saying you have to go to the meeting. It is part of your, you don't have to force, but you have to deliberate, find a way to deliberate with the client so that you come to understand why you need to be part of the meeting. Thank you. So C is man.
You're going for C. Okay. All right. She's going for C. Do you agree or you have an opposing view to what our colleague said, to what Madam Mary said?
So we agree.
You agree? See someone
I
going for
agree.
A. So I wanted the person to tell us why she's going for A or why he's going for A. That was Norabek, right? Norabek, why are you going for A? Well, don't follow what people are going.
Hello.
Yeah, hello.
Hello. I chose A because I know when it comes to alcohol withdrawal, we confront them. That is why I chose A.
Okay, so she says that she's using confrontation. So because of that, that's why she's going for A. We'll sit together. Yeah, Mr. Paul, your hand is also up.
But the
Yeah, Mr. Paul. Mr. Paul hands is up. So let Mr. Paul talk and then the next person can. Mr. Paul, go ahead.
okay. I'll go for C because option A, the Y will negate it. and the D, it is your decision. If you don't want to go, you don't have to. So that one is not more of therapeutic. And the option D, this one is the patient is autonomous. You have to take his or her own decision. So if you can't force treatment on the patient, so that's why option D2 is not appropriate. So option C, I think I see C to be better.
So it's also going for 6. Yeah. So the one who wanted to come in.
Yes. What's Amingo?
Yes, Mr. Isi.
Please, what is the therapeutic communication term for the C? That
Is that what is a therapeutic Yeah, rather throwing the question back to me. So you seem upset about the meeting. No, that is
I
you
like
seem
the
upset
question.
about it allows the client to talk more. So when you say you seem upset about the C, it's making the client, so the moment you say that, it will open up like more conversation. So the client will talk more and tell you why the client is more upset about it. So that is a statement telling the client like to incite more conversation about why the person is upset. Are you getting the point I'm making, Mr. Yusuf? So the C is the best option here. Okay. So the asking if the client is upset about the meeting encourages the client to identify. So that's why I was saying that it will let the client speak more. And you know that is what we say in mental health we do. Things that let clients speak, go for it. So you seem upset means that you are opening up a conversation where the clients can express themselves to you.
Hello.
Yes, hello.
Yeah, this is Evelyn here. Today is my first day joining.
All right.
I think you are right about your explanation why we chose C.
Okay.
For patients like that, we need to be very careful how we communicate with them. You don't have to choose options that will make you like indifferent, like you don't care about their feelings. So that's why you have to be more therapeutic and then try and get more information why they don't want to go. Maybe you can have an alternative solutions for them. So it's better you like be on their side and get more information why they don't want to do something. So I think C is the best option.
Yeah, thank you so much. Mr. Paul, you want to come in again?
Yeah, but the word sim is one of the English schools. They like that particular word. Sim is a flexible word to them. So any option that have that particular word, you have to consider it. So sim is a flexible word.
Yeah, you seem right.
Yeah, sim.
Yes,
Yeah,
yes,
that
that's
word.
true. Yeah, you seem upset. So, I mean, it opens up conversation. So the person will talk more about the issue. Okay. This is also quite straightforward, not to think too much about this question. A client is admitted to the inpatient adolescent unit after being arrested for attempting to sell cocaine to an undercover police officer. The nurse plans to write a behavioral contract to best promote compliance. The contract should be written A, abstractly, B, by the client alone, C, jointly by the client and the nurse, and D, jointly by the physician and the nurse. So definitely, this is also a very straightforward question that I believe nobody will get this question anyway and start thinking a lot about it, right? Well, you can't be thinking. Who knows? You always have to analyze your question very well and then come up with options you think best suits that very question you are answering. So we have, so this is very straightforward. I mean, it's supposed to be done between the nurse and then the client. So it has to be, that's where in when we're doing the behavioral or when we're doing personality disorders, we got to understand that if you need to initiate a written contract, you need to make sure you and the client, you are you are putting together the contract. So it wouldn't be like the client is saying that you have forced the thing on me. Okay. So it has to be something that has to be jointly put together between the nurse and the client. And then you strictly, you have to go by that contract, and you have to let the client understand that. I mean, this is where you are going with. If he goes contrary to that contract, there are consequences to that. Okay, so this is where you set a limit to be firm on it as well. That is this very question. A client who is actively hallucinating is brought to the hospital by friends. They say that the clients use either LSD or angel dust like PCP at a concert. Which of the following common symptoms or assessment findings indicate the client may have ingested PCP? We have dilated pupils, we have nystagmus, we have paranoia, we have altered mood. Which of these will be more specific to PCP? Mary.
Thank you very much. It says me right, you said first said the PCP, they are uppers. So once they are uppers, dilated people is a sign of
All these
uppers.
drugs are uppers. LSD, PCP are both uppers. So
Then this one there, I'm just I don't know which one is.
okay. Hey. All right. So Madam Mary, you go ahead with what you wanted to go for. Don't worry, okay? I was just wanted to
So
just say
I've gone for A, dilated people.
okay.
Mhm.
All right. Both of them are all uppers, okay? So all right. Is then the stagnants, okay? It is more, I mean, specific to that of PCP. The paranoia, the altered mood, as well as they are both PCP and LSD will cause it. Dilated pupils are more for LSD. So let's take note of this. I think this very question also has open up some
So
of this.
please come again.
I should
So
come
please.
again. Which one?
Yeah. What you were saying.
It's there. It's in the. It's what I'm saying is in the. It's in the slides. Okay, it's in the rationale. I'm saying that dilated pupils is more to LSD. Paranoia altered mood happens in both PCP and LSD. Nystagmus is, more to what we call PCP. All that I said is on the screen. So those of us following on the screen.
Please, can you display the question again?
This is the question. That someone has been, brought to the facility. The person is hallucinating. The friend says that the client used either LSD or PCP at the concert. They are not too sure of which drug the person used. Now, the question is that which findings would be more, which of the following common symptoms, common assessment findings indicate the client have ingested PCP? So we are looking at which symptom, if the client shows, will help you to say that it is PCP the client took and not LSD. And so we have dilated pupils, we have nystagmus, we have paranoia and altered mood. Now, you've got to understand that dilated pupils, yes, they are all, these two drugs are all uppers. And so under normal circumstances, we expect to see that the person will show the dilated people will happen with these two drugs. But specifically, the dilated pupils are more specific to what we call LSD intoxication or LSD use. And then the nystagmus is more of PCP use. Then paranoia and altered mood is for both LSD and PCP. So if someone is using LSD or PCP, the person is likely going to experience some form of paranoia symptoms and then altered mood behaviors. The nurse is providing care for a client undergoing opiate withdrawal. Opiate withdrawal causes severe physical discomfort and can be life-threatening. To minimize these effects, opioid users are commonly detoxified with A barbiturates, B amphetamine, C methadone, D benzodiazepines. I think this is also quite common. One of the common areas or common questions you come across, it's also a question of this sort. And it's very straightforward, right? If you followed me very well when I was talking about management of withdrawal, even if you don't know, and you followed me very well during management of withdrawal of the various substances, opiates and all that, you get to understand what to do for this very question here. Okay. Yeah, so I see you're going for C, of course. And methadone is one of the opioids that are clinically used to treat opioid withdrawals, right? So we said that if someone is withdrawing from the drug, opiate, so you have to look at what the person is withdrawing from. You introduce what you call the drug at a low dose so as to prevent, to manage the withdrawal. So methadone is used to detoxify opiate users because it binds with what we call opioid receptors and what we call something. So it's that kind of feeling the person gets after taking what we call the opiates. Person takes methadone. So methadone is actually specifically to be used in treating what we call opioid withdrawals. Okay. And I believe we all know this.
Sir,
Yes, hello.
please, I want to ask, with the methadone, can we include with naloxone?
Naloxone. Okay, so naloxone is more of like an antidote. Yes, so naloxone will come in, especially if the person is having respiratory depression. So the naloxone is used when the person has abused the opiate and the person when the person is intoxicated on the opiate, that is when naloxone will come in because the opiate is a downer. And so when you are intoxicated on opiate, respiratory depression comes in, right? So we don't give naloxone during what we call hallucination, during withdrawal. When you give naloxone during withdrawal, you are going to cause the person to withdraw more. Are you getting the point I'm making?
Yes, please.
So we don't give naloxone when one is withdrawing. We give naloxone when one is intoxicated on the opiate because it serves as an antidote to opiate. So it will help reduce the amount of the opioid in the system, reverse the respiratory depression. However, if you are withdrawing from, I've met questions. Thank you for bringing this up. I've met questions on that as well. Someone withdrawing from an opiate, then they ask you possible treatment or possible medication you expect a healthcare provider to give. If you choose naloxone, you are wrong for withdrawal in opioids, because when you give naloxone, you are going to cause the person problem to worsen, because it means that you are causing the lethal amount of the opioid in the system to rather go, and the person will keep withdrawing. So in that instant, you introduce what we call methadone, not naloxone. Naloxone is for intoxication.
Okay, thank you.
All right, you're welcome. Which of the following signs should the nurse expect in a client with known amphetamine overdose? This is also very easy, right? Known amphetamine overdose. So think, is amphetamine an upper or a downer? Is amphetamine an upper or a downer? Question to the upper. An upper. The person is what? Overdose on an upper. So I said, don't choose symptoms. So if you are overdose on an upper, look into this question. What are the things that indicate that things are going up? And you are likely getting your option correct here.
Tachycardia.
So that's straightforward tachycardia, right? It's an upper, intoxicated on an upper or overdose on an upper. So therefore, we expect to see that things will go up in the person. Okay. Is there more? So that is tachycardia. This question says that the nurse is caring for, so the T did not come. So the question is, the nurse is caring for a client who she believes has been abusing opiates. Assessment findings in a client abusing opiates, such as morphine. So assessment findings in a client abusing opiates, such as morphine include, so, I mean, we are looking at findings to what we call opioids like morphine overdose. Now, we have A, dilated pupils and slurred speech. B, rapid speech and agitation. C, dilated pupils and agitation. D is an inferior and constricted pupils. So which of these do we think will happen to someone who is abusing opiates like morphine? Someone should speak for us.
Flamingo.
Hello.
I'll choose A because of the slurred speech. Because
of the slurred speech, okay.
Because morphine is a downer, isn't it? So when you look at the B, because of the agitation is out. C2 because of the agitation is out. Then D2 because of the euphoria is out. So then you are left with the A. So I'll go with A.
Okay, she's going with A. That certain part of the other options makes some of the options also to become wrong. So if she ends up going for A, that dilated pupils and slurred speech. Okay. Is that what we are going for? Or someone with the different view or options? I'm going for D. Someone is going for D, Madam Esther.
Hello, sir. I'm also going for D because of the constricted pupils.
Yes.
So she's also concentrating on the constricted pupils. The question is a little bit confusing. All right.
Very confusing because D.
So
Hey,
the
what?
yes, Madam Carrie
What confusing is because of the other one
because of the euphoria, right?
No, not because of the euphoria. You know, the first question that we did that they said dilated, the PCP one. I was thinking that if somebody is on an upper, like the pupils should be constricted. Because if someone dies, the pupils are dilated. So everything is dead in the body. So the pupil is dilated. But if you have an upper, but because you answered that one that nystagmus and that the L whatever
No,
LDS.
that is upper.
That was an upper. But
Yes.
when we read the
Morphine is a
we
downer.
said, yeah, no, when we read the rationale for that one, you said nystagmus is correct. And
Yes.
and that the
It was
dilated
between
people
those two
is
drugs. The two drugs are all uppers. That's why he said that.
The two drugs are all uppers.
So it's the
So
nystagmus that was.
another circumstance, you would think like, I mean, nystagmus, dilated people, both two drugs will cause it. I hope you understand. If let's
so
say
that means
let's
if
get
you
a
have
question.
an upper,
Yes.
sir, please, if you take an upper, your people should be dilated. Is that what?
Yes, generally, yes.
Okay.
Yes. Unless it is specific with like that question.
That's PCP. Then
Let's say you get a question. The question is someone has taken a central nervous system stimulant. What are the possible, without them being specific as whether it is PCP or it is LSD? And it's just a question like a central nervous system stimulant or a hallucinogen. What are some of the things you expect to see? Of course, you expect to see the nystagmus, you expect to see the dilated pupils. Unless it is specific, that is when you tend to go either it is nystagmus or it is dilated people. Then you look at what drug they are asking you of.
Okay. All right. Thank you.
All right.
Hello, Boss Amingo.
Yes, madam.
Please, this question, was it talking about withdrawal or it was
abusing? So whenever you hear of abusing, it means intoxication.
then and the intoxication and this drug is an upper.
It's a downer, morphine, opioid. Don't
Downer, okay. Then in downers, I think we have slurred speech, signs and symptoms of the those in down.
So you know why that other options are wrong? Because of where is a slurred speech, dilated pupils. It makes it wrong. It's dilated pupils and slurred speech. So the dilated pupil is making that option wrong. Now the B, agitation, is that there wouldn't be agitation if someone has taken a downer or has over abused a downer. There's also rapid speech. These people tend to have slurred speech. So automatically for the B, the two sentences there are all out. Now we take the C, dilated people's agitation. It's also the two all are wrong. For euphoria happens in someone. I think for euphoria it happens in downers.
Okay.
If you over abuse a downer, you become more euphoric, and then the constricted people, as we all know, is a downer. So the thing will get there, people will get constricted.
Boss Amingo.
Hello, yes.
Hey. Please, I don't want to memorize this.
No, don't memorize it. I don't even want anybody to memorize. Please don't memorize. Just understand.
Yes. That's what I'm trying to do. But then, let me know if like someone or a client is abusing a downer or an upper. What's the direction of the signs and symptoms? Is it going down or up? That is confusing. Whether you are abusing.
So what I'm saying is that finish your question. Are you done with so let me summarize this for us. Okay, I'm saying that uppers.
No. The question is that.
Ms. Aisif. Hello, Ms. Aisif. Yeah, it's gone off.
Yes, can you hear me?
Yeah,
I'm on.
Yeah, come again.
Hello.
Yeah, come
Yes,
again.
I'm saying that.
Continue.
What is the direction of the signs and symptoms? Yes, I'm speaking.
Uh-huh.
I'm asking of the directions of the signs
Okay.
and symptoms of when a client abuses a downer or an
Okay.
upper. What's the direction? I just want to
Okay.
know that whether it's going down
Okay.
or up.
Let's take this line. Okay. Thank you. So let's take this line. Okay. I'm doing something on the screen. For those who are monitoring on the screen, I'm using upper here. Okay. And I'm using downer D. Let's talk about overdose. Okay. Overdose here. Now, overdose is the same as intoxication. Overdose is the same as intoxication. When you overdose an upper, or when you get intoxicated on upper, the symptoms is that it will go up, things will go up. Now, when you intoxicated on a downer, I'm taking again, when you intoxicated on a downer, things will come down. Or when you overdose a downer, things will come down. So I said that don't chew the findings or the assessment findings. Understand it this way, so that when you get your question, so looking at this very question or these options, okay, we can even group them. Are you getting me? So when you group, let me go back to the question. So this question is a morphine. We know morphine is a one. Morphine is a downer. The question is asking about things to expect in intoxication. The person abusing it, over abuse. So what do you expect? So we have slur speech. Slur is down. So you get a slur speech here, right? Then you go through. So I'm just grouping the symptoms that are here. Dilated pupils is not down, it's up. So we'll not bring it here. Then we have rapid speech agitation. It's not part of down symptoms. Then dilated pupils agitation, not part. I mean, dilated pupils means that things are up. Agitation means things are up. For inferior, see, inferior is not like the person is in inferior. It's like utrimwa of the baby. I'm sorry for using the chi, but it's like within you, you feel like a little bit more happy, that kind of thing. Okay, you become a little bit more inferior. So let's understand that inferior is part of downness in terms of when you overdose a downer. So there is inferior, and then there is constricted pupils. Constricted pupils means that things are things are getting closer, or the pupils are getting closer, means that it is coming down. I hope you get me. So if you put these things together, you can now strike this one, the first one out. It's only the slur speech that falls under, I mean, downness overdose. Dilated pupils will not fall under. So that option is totally wrong. This one is also wrong. We've got to know that this one is also, you'll be left with only the D. So I'm saying that when you get your question, you can use this what I just drew. I just drew a table. Know that when you are intoxicated on upper, you go up. Or when you over abuse upper, you go up. When you over abuse a downer, you come down. Now let's look at the opposite. That is when you are withdrawing. Now, when you are withdrawing from these medications, again, just put your table together. This is our table. You have upper here, you have a downer here. We are looking at withdrawal, right? We are looking at withdrawal. So when you are withdrawing on upper, you rather go down, you don't go up. And when you are withdrawing on a downer, you go up, you don't go down. That is simple. So that is where your dilated pupils will come in. That is where your rapid, in terms of speech, it will be more rapid speech. The person becomes agitated. Okay, I mean tachycardia, hypertension, diarrhea, vomiting will all fall under this. Then the opposite will also come here for someone who is withdrawing on an upper. Am I able to make sense here?
Yes. So let me clarify some. So meaning that you know the withdrawal, the drug quantity in the blood is less in your
It's
blood.
less, yes, sure.
So the desired effects of the drug, what is supposed to achieve, once the drug is less in the blood, you will not achieve that. So let's say if the drug is supposed to make you happy and it is less in the blood, meaning you will not be happy. So that
Yes,
is basically how the signs and symptoms to cancer. So if you know how the drug functions, then you are safe to go with to know when it's withdrawal or intoxication. Thank you.
exactly. Thank you. Thank you, madam.
Can I
Sir,
say something?
Hello, one after
sir,
the other. Okay, let's
Yeah.
address the issues one after the other. I'll
Okay.
be very grateful if we use the raise hand button so I could call you one after the other. Okay. Madam Carol, I heard your voice. So Madam Carol, let's go.
okay, sir. So does it mean when a patient, when somebody is given an antidote to patients overdoses medication and the patient is given an antidote, does the antidote serves like a withdrawal something? Because they begin to act in the opposite. If you give naloxone to, okay, you give an antidote of a medication to a patient, the patient starts to behave in the opposite direction. So does the antidote work as like a withdrawal? It's my mind is a
No,
bit
the
mixed up.
antidote is to reduce the excess of the medication in the system and reverse the side effects of the medication. So antidotes, you have taken more of the medication. We want to kind of give something that will help reduce the content of the medication in your system and also controls the side effects of the medication you have taken in excess. So that is where the antidote comes in. So the antidote is to help reduce the quantity of the drug in your system. So antidotes are only used during overdose of a certain drug. So let's say you have overdosed an opioid. When you overdose an opioid, because it's a downer, you go down. One main thing in opioid overdose is respiratory depression. So in order to prevent the, respiratory collapse or arrest or something like that, we have to give the naloxone so that the naloxone will help to reduce the amount of the opioid in your system and also help to reduce or prevent the respiratory arrest that can happen as a result of the medication you have taken. Now, Carol, are you getting the point I'm making?
Yes, sir, it's okay. Thank you.
Yes, Madam Esther.
So I'm seeing agitation here as part of the things, and I think they'll be agitated because the central nervous system is involved. So the agitation, I don't think is just for the APES because as part of this rationale, agitation too is listed, which
Yes,
is yeah.
So agitations can equally happen instead. Thank you. Yeah, thank you for drawing my attention to it. Yeah. So yes, so you could equally have agitation. But if you look at the ones that the agitation was applied to, it was agitation and dilated pupils. So that is what was making that very option too wrong. So thank you for drawing my
You're welcome. And I wanted to add on to the euphoria. You know,
all right.
euphoria is like everything is cool. You're in your own world where things are just cool and
Can you
low
come
and
again?
smooth. Like euphoria.
Yeah.
Euphoria is the kind of feeling that makes when you see the guys who do the traumas, like their eyes
Yeah.
are just so bad. Like
Yeah.
that's the kind of feeling they feel cool and down. Like
Cool. They feel
there's
cool.
no
Is that yes?
problem. Yes, cool. Like
Yeah.
yeah.
All
So
right.
that's the euphoria too.
Okay. All right. That's fine. Thank you for your contribution there, guys. I think our time is up. Talk about the two differences. The fact that dementia is more chronic in nature and the problem is progressive. The person will not literally, recover. It's just that it is a stage that the person find him or herself in that will determine how the person will function. So dementia, it's progressive deterioration in the intellectual functioning. mostly as a result of structural or functional changes within the brain. Mostly it leads to long-term and short-term memory loss, that is amnesia. We got to understand that it also affects impairment in judgment, abstract thinking, and then problem-solving ability. People who have dementia are mostly affected in these areas. One of the major problems of people with dementia are self-care. I talked about it. So you have to assist them. They might literally end up in what we call long-term care facilities for you to help them to meet their basic needs and other self-care needs. Dementia-like symptoms, like I said, could be as a result of certain physiological problems. And so before you diagnose someone of having what we call dementia, you need to rule out the symptoms that they are not as a result of other physiological conditions, okay? And I talked about even severe infection, that is sepsis, could lead to what we call someone experiencing some form of memory loss, confusion. And so that is more of delirium. Electrolyte imbalances or could contribute to one exhibiting some form of dementia-like symptoms. So before you diagnose someone, before you arrive at the fact that someone is having dementia, you might have ruled out the physiological conditions first before you arrive at your conclusion. I did also mention that Alzheimer's disease is one of the leading cause, or the most common cause for what we call Alzheimer's disease. Sorry, it's one of the most common cause for dementia. And so mostly when you are looking at the stages, some of the books will stages of, let's say, Alzheimer's disease is the same as stages of dementia. And so when we talk about Alzheimer's disease in terms of the stages and then the functionality that the individual can perform, or what the individual can perform at each stage, and then you meet a question and the question is asking you about dementia, just understand that it's the same as the stages of what we call Alzheimer's disease. So we have the stage 1, stage 2, stage 3, the last stage being stage 4. And so we'll look, I think I did mention about it the other day as well, that Alzheimer's disease results in, or is an irreversible form of senile dementia that mostly caused by what we call nerve cell deterioration. So the issue has to do with your brain cells, your nerve cells, where, at the end of the day, it leads to deterioration in memory, you being able to remember present and the future things, and then abstract thinking ability all gets affected. The individual mostly experiences cognitive deterioration and then progressive loss of ability to carry out activities of daily living. Just like I was saying, in someone with what you call dementia, their major problem has to do with activities of daily living. That is where they are mostly affected. So in that instance, like I said, you need to assist the patient to be able to function very well, or assist the patient to meet those needs. I also did mention that these people mostly ends up in long-term care facilities, so that because sometimes they become very, very difficult for family to even take care of them, especially when they get into the third stage, or the third stage, where wandering, confusion is more, the person will rely solely on the family. Sometimes your family will end up sending the person to a long-term care facility for the person to be taken care of. The stages, like I said, we have the first stage, that is the mild stage, or the mild stage of stage 1. We have stage 2, that is moderate. Stage 3, moderate to severe. And the last stage has to do with at the end stage, that's where everything is gone. And so I made mention that at stage 1, the person major problem has to do with forgetfulness. At the mild stage, there's forgetfulness, that is mild memory problems, that is forgetfulness. They sometimes find it difficult to find the right words to describe whatever they want to describe. And then occasional confusion can happen. They also tend to have some form of changes in personality and then behavior. At stage 1, what are some of the things that you expect the person to be able to do at stage 1? And so if someone has Alzheimer's disease or someone is having dementia at stage 1, the person virtually retains most of the, ability to perform activities of daily living. So the individual can still function independently in their daily activity. But then they sometimes experience some form of challenges when they are engaging in complex tasks. And so if the task requires more thinking, complex ones, that is where they do need some assistance. And but when it comes to their normal daily life or daily activity, self-care, at stage 1, the person is able to retain those kind of abilities to perform. However, if the task, it's more complex, then the person will experience some challenges and will need what we call help over them. Then we talk about stage 2. So stage 2, that is moderate stage. Their main problem over there is confusion. So, confusion is there. The memory loss is more pronounced. They have difficulty with what we call language at stage 2 or the moderate stage. And then challenges with recognizing familiar faces and then places as well. So confusion is there. Memory loss is more pronounced. Find it difficult to recognize familiar places and faces. And then they tend to have difficulty with what we call language. At stage 2, the individual may need help with daily tasks, okay, such as bathing, dressing, and preparing meal. And so at the stage 2, they don't rely solely on, let's say, family member, or they don't rely solely on people for help. They need a help to be able to perform what we call the daily tasks like bathing, feeding, cooking, and those kind of activities. They will need help, but not 100% that whoever is taking care of me should do it for me. They are able to do some, but we need help. But at phase 1 or stage 1, we said that they retain virtually that ability to bath, to eat, and then grooming and all that. But those that require more complex or the complex tasks, that's where we need the help. So let's get the understanding from here that at stage 2, they will need help to be able. The word is help. They need help to be able to do, activities of daily living. Then at stage 3, that is moderate to severe phase, the individual tends to have what we call, that is ambulatory dementia. The reason why it is ambulatory, they are terming it as ambulatory dementia is that is where wandering is more pronounced, or wandering happens a lot of times in what we call stage 3, that's moderate to severe. That's where you have the individual tends to confusion increases, and then the individual tends to become be moving around anyhow purposelessly in the individual's environment. So that is why they are terming it as ambulatory dementia. And so at this end, the person is having what we call significant loss of memory and then cognitive ability, difficulty with communication, and then profound personality changes. So there's profound personality changes occurring at what we call stage 3. At stage 3, what can the individual do? This time on, the individual will require full-time care, and they experience behavioral issues like wandering, agitation, and then hallucination. And so at stage 3, they depend fully on the significant other, or they depend fully on whoever is responsible for their upkeep. And so stage 2, they require help. Stage 3, they require full self-care. So whoever is taking care of, you are responsible to take care of everything. At that point, the person cannot do anything. And so at stage 3, they require what we call full-time care and may experience the behavioral issues, talk of wandering, agitation, and then hallucinations can occur at this end. Stage 4, if the person does not get the needed help and then support, end up in stage 4 and everything is gone. And so that is the various stages of what we call dementia or Alzheimer's disease, and then what the individual can do at each stage. when you take the various issues that accompanies them, we talk about communication issue, we talk about memory problem. So there are certain terms here or certain terms we need to understand them, and we need to know their meanings in case we come across them in our question. So the first one is, I think I made mention of it already, that is amnesia, where the individual fails to recognize, familiar objects or familiar faces or familiar objects, things that the person probably might have seen before. This time around, the person is not able to recognize those objects again. Then amnesia, as we all know, has to do with memory loss. And so memory loss that's caused by brain degeneration. Aphasia, that is language disturbance in understanding and expressing what we call spoken words. And so the individual tend to have difficulty with understanding and then expressing what we call spoken words. So when you speak to them, they find it difficult to understand what you are telling them. And then they also find it difficult to also express themselves using spoken words. Then we have the aprasia, which is difficulty with what we call body activity or motor activity, despite intact motor function. So inability to perform motor activities is what we call aprasia. So we just need to understand this term so that in case we meet them anywhere, we can know the meaning. I think I met some questions somewhere that were asking about these things, and they will bring the terms, and then you have to spot what the term means. And so that is it. So a general intervention for someone who is having dementia or someone with Alzheimer's disease, you need to identify, reinforce, retain skills, especially at the initial stage or at stage 1. We said that the person is able to retain virtually almost all the skills they need to perform what we call activities of daily living. So you have to identify the individual strengths or skills and assist the person to retain them and perform them. You provide, continuity of care. So what the individual can do and what the person cannot do, you assist the person to complete those tasks. You have to frequent reorientation. One of their major problems for confusion. And so you need to orient your client to the environment. You furnish what we call the room with familiar possessions. So you always have to make sure that, because already these people tend to have issues with even sometimes recognizing familiar faces. So why would you then want to bring in things that the person might have not seen before? And so you try to make sure that you are furnishing the individual's environment with familiar possessions. You acknowledge their feelings, especially when they become agitated. At stage 3, when they are wondering, when they become more agitated, you need to acknowledge, those kind of behaviors, and then allow them to express themselves, and then their feelings to acknowledge it. You need to assist the client and the family to manage memory deficits and behavioral changes. To encourage them, the family members, to express their feelings about care. In fact, it is very, very, very draining. Those of us probably in overseas that we are working in the home care. Okay, home care centers. I believe over there these things are more common, and so when you are caring for someone with dementia, it's very draining, and so the family will need that kind of support. And so you need to encourage the family members to continue to express their feelings, how difficult it is in caring for their family member and all that, which is very, very necessary. Then you need to also provide what we call care with support, identify resource centers and groups. Resource centers are very important, especially if the person probably lives with maybe only the spouse or something like that, and then financially they are draining, the support is not too good in the house. They will need to rely on what we call community resource centers. And so you need to identify those resource centers and support groups that are available to what we call the patient, so that family can also rely on such support groups. Monitor what we call the client's activities of daily living. We talked about that. Remind the client how to perform their self-care. If they can do that, remind them, assist them to help them to maintain independence. For those that can perform activities independently, assist them, help them to maintain that form of independence. Then you provide them with consistent routine. It is very, very important. People who always have who are mostly confused, or one of their major problems are confusion. You need to make sure that you are maintaining consistency with care. If you need to have a well-planned activity that the individual will follow every day, don't try to jam the activities up. When you do that, the person becomes more confused. We don't know what I did yesterday. Today, you are bringing in something else for me to do. Maybe when I woke up first, I have to, brush my teeth, wash my face in order. But today, you are telling me to go and start bathing first before I come and, brush my teeth. When you do that, I'll come and wash my face, whatever I do. When you do that, the person becomes more confused. So you need to maintain consistency in terms of daily routines. You provide the client with, exercise, such as walking with escorts. Provide activities. Avoid activities that tax the memory. What it means is that activities that require more thinking. Okay, that's why complex tasks, these people, even at stage 1 where we say that they can perform activities, we say that complex tasks, they find challenges with that or difficulty with that. So why would you give them taxes that will require more thinking or require, the person to use more of, their brain and all that. So you need to give them simple tasks that they can perform, and then give them ample time to complete for the taxes you give them afterward. You have to use constant encouragement with the clients with simple step-by-step approach, and then provide the clients with activities that distract and occupy their mind, such as listening to music, coloring, watching television, and all that, to get them more engaged. We said that simple tasks is very important. So provide them with mental stimulation activities, okay, with simple games or activities, things that would let them use, like, mental stimulation, okay, but not complex one, like puzzles that are more easy to work with, so that they kind of, it will help to improve upon their memory. Then one of their major problem I did mention, it's what? Wandering. And so we said that at stage 3, that is ambulatory dementia, and that is where you expect the individual to be wandering more often. And so wandering is where the individual tends to get more confused. He tends to walk around purposelessly, in their environment without any purpose. You see the person walking around. So we need to understand what to do for the individual when the person is wandering. So wandering is a common behavior, like I said, where the individual with dementia are unable to find their way, whilst pursuing a needed or a goal. They mostly wanders when they tend to have confusion, disorientation, the desire to return to, a past place. Probably they want to go back to wherever they come from. Maybe you send them to, a long-term care facility. The patient wants to go back, and because of that, becomes more confused and start wandering around or start moving around. So we need to understand that they mostly wanders when the confusion is more pronounced, where the person will be moving around most of the times. And so for clients who are wondering, what are things that you need to do for the client? You need to provide the client with a safe environment, free of clutter, and then hazardous objects. Very, very important. We know that we said that wandering is a stage where the individual walks around or move around the environment purposelessly, and then they walk around just like that. And so you have to make sure that the environment is safe for the client to wander. And during wandering, you don't force the client to come back or to come, and then you don't force the client. So allow the client to wander around. Make sure that the environment is safe. There is no any form of devices or any form of wires that can cause the client to fall, or any form of hazardous object in the client environment. Make sure the environment is safe for the client. Provide safe ambulation, including mobility care, aids, comfortable and well-fitting shoes. So that's just how I was saying, wandering is part of their problem. So you don't tell them, or don't force them to come and sit down when you see them wandering. Allow them to wander, but make sure that the environment is safe. So you have to provide them with what you call, safe ambulation. Safe ambulation means that if the person is wandering, make sure that the movement, whatever the person is doing, is more safe. So you provide the person with mobility aids, like comfortable and well-fitting shoes, so the person can easily move around without any form of pain. Provide close, frequent supervision to your client. You need to close all doors. All doors need to be closed. So close and secure doors. Because if the client is wandering and then the door is open, by the time you realize the client is nowhere to be found, the client might have left the compound and then you don't know where the client has gone. Okay, so you have to make sure that the doors are well locked or secure so that the client cannot open and go out during times of wandering. You need to have identification bracelets on the client and the electronic surveillance so that if the client probably maybe escapes during wandering, we can easily trace where the client might have parked. And then if the client may become missing, so that you can also easily identify your client. Encourage what we call rest periods in the afternoon, because wandering mostly worsens at night. Okay. And so during the daytime, you might have to provide some form of or during afternoon, you might encourage what we call period of rest, because in the night, they might become more confused and then wandering will become more pronounced at night. So you have to encourage rest period in the afternoon. You need to provide them with regular supervised exercise or walking programs. Then we talk about sundowning. So sundowning, it's more pronounced or where the wandering increases at late afternoon and evening. So sundowning is just like wandering, but this time around, we are looking at the time that the confusion, the wandering is happening. So the wandering, the confusion happens around late afternoon and then evening, and that is what we call sundowning. So it is characterized by pronounced increase in symptoms and then problem behaviors in the evening. So it is more common, or it happens mostly at late afternoon and evening, where the wandering increases, the confusion increases, and then the behavioral issues also increases. You need to provide the clients with what we call a safe environment. Provide a safe environment. Providing a safe environment is a priority in the care of a client with what we call Alzheimer's disease. And so for people with Alzheimer's disease, like I said, they're wandering, you cannot tell them not to wander, but you need to make sure that safety is the thing that you need to target, or safety is very, very important, so that when they are wandering around, they don't get injury, or they don't get those forms of injuries. And so these are some of the things that at least we need to know when it comes to wandering in a client with what we call dementia. Then there are communication disorders. Yes, Mr. Isik, you understand.
Hello.
Yeah,
please, the point under this wondering. Let me look at it again and then notify
which
you.
points?
Under wondering, please, you go back a bit.
Yes.
You said encourage rest periods in the afternoon because wandering wasn't at 9. And then I thought that that one rest is encouraged in the afternoon, the client will rather gain more energy. Is that not the
client
case?
becomes what?
I'm saying that one rest is encouraged in the afternoon. So it means that the client would rather gain more energy in the night. Maybe the rest.
Is that what you have to know? when you get tired, let me throw this question back to you. When you get tired during the day, are you able to sleep at night?
When you get tired during the
Yes,
day.
I'm throwing this question back to you that when you get tired, very tired in the day, when you get back to the house, how do you mostly feel?
Sleepy, very tired and sleepy.
Just tired.
Very tired and sleepy.
So you are able to sleep, right?
Yes, when I'm tired, I'll sleep.
When you are tired, you sleep.
Yes. Oh,
that's logic. Okay. Encourage, rest. Resting doesn't mean that the person should sleep. Okay. Rest means that allow the person to rest, not to engage too much so that in the night the person becomes tired and cannot do anything. That is what, and then becomes more confused at night, because the wandering is not all about the walking. Confusion is there. And so if the person is more engaged during the afternoon time, look at a time where it's an afternoon, so that in the night the person can now rest and then sleep. But if you engage the person in the afternoon, the person gets to the night and becomes more confused, tired. These people are not like me and you, where we have that energy to be able to sleep, like how you are saying that as for you, if you are tired in the day, you are able to sleep. Remember, these people, your energy level is not like you. So
okay. For myself, I thought the resting could include sleeping. Yeah.
all right. Oh my God. That you see, it's fine, okay. All right. So that is it. Encourage, rest period. It's not going to destroy the person in the night. Yes, Madam Nenek, yeah.
So, sir,
Yes.
so they should rather rest in the afternoon, right?
Yes.
Ah,
Is it?
oh,
And then late afternoon too. Sundowning also, I said that sundowning pronounces more in late afternoon to the evening. So if you allow the person to rest at that point, it will also help to even prevent issues of sundowning.
oh, okay.
Yes. So for afternoon, let the person take some form of rest during the afternoon, so the person becomes more relaxed and becomes more because if the person become more demanding, or like you put more pressure on the person, that's where the confusion sets in. And so during the afternoon time, you allow the person to rest.
Okay, thank you.
But
Yes, Ms. Aisi, if you want to come in again. All right. A communication problem. So let's look at how to care for them.
Samingo.
Yes, hello.
Hello.
Yes.
But Samingo,
I can hear you. Go ahead, Ms. Aisi.
please, what's the difference between resting and then napping? Yes.
That's the difference. That's why I didn't use the word nap.
Yeah. Taking a nap.
Napping. Listen. Napping, you can be resting without even closing your eye, right? But in napping, you take a bit of brief kind of sleep. In napping, or am I not getting? Is that not the keys between napping? This is between napping and rest.
Yeah.
Resting means allow the person to be more comfortable in the day, or make the person comfortable. That is resting. Napping involves a little bit of the person sleeping for a while, for a short period. So I get your point, where if you let a person take a nap or sleep during afternoon, the person will find it difficult to sleep at night. And then the person will be wondering. That is why I didn't use the word take a nap. But when the person takes a nap, it will be very difficult for the person to, sleep at night. But resting means make the person comfortable. So that's why I'm careful of choosing the words. Or you think nap and then rest is the same, Mr. Yusuf? Are those two words the same? Sorry, Mr. Yusuf. I want to get yes. Do you think rest and
that
nap?
was my thought.
That's it. But it's not the same. The two are not the same. Okay, the two words are the two words are not the same. All right, let's continue. But if anyone has any other thing, the person can bring up from. So in communication, it's very simple. We said that these people tend to have issues with understanding spoken words and then expressing themselves to using spoken words. So you need to understand how to communicate with them, when you are communicating. So the other disorders are mostly has to do with expressive receptive disorders, that has to do with speech sound disorders, or they tend to have speech sound disorders, that is phonical disorders, then childhood onset fluency disorders, that is stuttering disorders, and then social communication disorders, where they have impaired social communication. So these are the areas where in terms of communication, they tend to develop, the issues around them. You need to adapt to the communication level of your clients. If the person is having dementia and have difficulty understanding you when you talk to them, and if they also have difficulty expressing themselves, you need to adapt to their communication, level of communication needs, so that you can pay attention to them, especially when they are using nonverbal communication, or when they are using, we pay attention to nonverbal cues, okay, and then you use a firm volume and a low pitch voice to communicate. When you are communicating with these people, you don't shout. You need to make sure that your voice is low tone and it has to be firm. So firm volume and low pitch voice to communicate. You need to stand directly with your clients when you are talking to them. Face them one-to-one in order to maintain what you call eye contact. Very, very important point. You give them ample time to respond to you when you are communicating with them. You have to use a calm, reassuring voice. You do not have to speak loudly when you are, unless the client is having, hearing impairment or something like that. But even with that, you need to make sure that your voice is using normal voice and all that. Don't shout at your client. Use gestures if the client is unable to understand spoken words. Speak slowly, clearly, using short and then simple sentences. Ask one question at a time and give one direction at a time. Repeat question if necessary, but do not rephrase. Do not rephrase, but you have to repeat if you need to repeat yourself. So if you say something, a client says that they didn't hear you, you need to repeat what you said, but don't try to rephrase whatever you said. Provide, because it might mean that the client might presume that to be like you have changed whatever you said. And so you need to repeat what you said so client can hear you clearly. Provide alternate means of communication for your clients. You have to minimize external noise in a client environment when you are communicating with a client to prevent any form of distraction. For those with impaired judgment, you have to make sure that you remove throw rags, especially throw rags is also even fall under wandering, someone who is wandering. So throw rags is like when they leave rag around anyhow and then it's not well fixed. You need to remove throw rags, toxic substance, anything the client can fix, dangerous electrical appliances from the environment, and then you need to reduce hot water heater temperature. Patients.
Hello, Boss Amingo.
Yeah, hello, madam.
Please, can you go back so that I show you some statement? I didn't understand. Okay, use quotamine gestures instead in the client if the client is unable to understand spoken words. Please, can you explain it?
I talked about it. I use gestures, or is it the word they put time in? You want to know what hand come in? Is that what?
Pantomime. Yes,
Uh-huh.
please.
I made mention that you need to use gestures. Okay, so it's just about using gestures to help your client to, communicate. Okay, so it has different types. Using illustrations, different forms of like gestures. When it comes to gestures, you have different ways to use gestures. Okay, it can be imitating action for your client. It could be using gestures to stress a point, and then acting out ideas. So like you act, and then the client will understand you how you want. So it just simply, the use of gestures. If the client cannot understand what we call speaking words, okay.
Thank you.
So it's just the pantomime or whatever is there is just like an English word then
Okay,
indicating
thank
the use
you
of
very
gestures in communicating. Yes. All right. So I've talked about the fact that we need to remove throw rags from client's environment. Any form of toxic substance that the client can go and then pick it and drink. You need to pick it from client's environment. Make sure that electrical cables are well fixed, and then the dangerous ones are also removed from client's environment. Hot water heater temperature needs to be reduced because these people might not be able to, in terms of if the thing is too hot, they might tend to burn themselves. So you need to make sure that you reduce the hot water heater temperature to prevent burns. In terms of altered thought processes, you need to call them by their name. You need to maintain their personality. So you need to call them by their name. You need to orient your client frequently using familiar objects. We talked about it. You need to also have calendar placed in the client's room, and the clock is also visible so that clients will know time and then the month, the day in which the client finds themselves in. So you need to have calendar and then clock visible in place in the client room. Maintain familiar routines, allow the client to release, and then make taxes that are very simple for clients to allow time for clients to complete tasks. We've talked about it. Have to provide positive feedback to clients if the client is able to engage in certain positive behaviors. So with sleep patterns, allow the client to wander in a safe place until the client becomes tired. That's why I said that. When the client is wandering, we don't stop the client that they shouldn't wander. You need to make sure that you are using, you allow them to wander around safely. Then you prevent shadows in the room by using indirect light. So now the shadows mostly, the shadows mostly causes what we call sundowning. When especially during late afternoon, when the shadow is thrown into the room, it mostly leads to what we call sundowning. So you have to make sure that the room there is you prevent shadows in the room by using indirect light. And then you have to also make sure that your curtains are closed during the late afternoon to prevent shadows from entering client's room. Avoid the use of hypnotics, medication that can cause more confusions and then aggravate what we call sundowning effects. For those who are agitating, you have to assess the reason why they are agitation, because the agitation could be anxiety, it could be because they might have not met their physical needs, and so that is what is causing them to become more agitated. Or it could be that the confusion is becoming more. So assess the client to find out what is actually causing their confusion. You reassure them. You remove items that can be more dangerous when the client is more agitated. Approach your clients slowly and calmly from the front. Speak using gestures, and then you move slowly. You have to make sure that there is no form of distracting stimuli in a client's environment. So remove the client to a less stressful environment. Decrease excess stimuli. you need to use gentle touch when you are, you want to touch them or you want to, move them. Do not argue with your clients or force the client to do something when they are agitating. So that is on what we call dementia or Alzheimer's disease and the various issues or areas that we tend to have deficits and how to assist them to meet those deficits. So if you have any input or any question you want to make based on whatever I've said or whatever has been discussed so far, you can bring it up for us to look at it together. Before I do my eating disorder very briefly, and then we move on. Mr. Richmond.
Okay. Please, I want to ask this kind of people, what kind of medication can you use to manage them? Or there's no any medication in managing the dementia?
Medication to manage which part of their problem?
No, in your presentation, you made mention there's confusion, wandering, and sometimes agitation.
Yeah.
So I want to find out maybe if there are some medication that they can use in managing those signs and symptoms.
Oh, so generally, I think there are medications to help memantine and those kind of things. If you have come across memantine before, it helps to improve memory function and all those things. So they are mostly used in Alzheimer's disease. So those are to help improve on the memory. But when it comes to the confusion, when it comes to the agitation and those things, mostly their cause, mostly it has an underlying cause. So let's say the person is wandering around. Mostly if they are wandering, it is either maybe they have not, their self-care hasn't been met. So you just have to, support them, let them, just like I was saying, when they are wandering, allow them to wander. They are tired. When they are tired, they will rest. When they rest, patient becomes calm. So their problem just revolves around confusion and all that. So there is no specific medication you say that you're going to give for the confusion to stop. There's no kind of medication to help say the confusion to stop. Or when they become agitated, that is where I was saying that we talked about in terms of agitation. It's all about supporting the client and then making sure the environment is safe. If the client is agitated, look at what is causing the agitation. If you spot what is causing that, if it's what the client is hungry, probably you need to provide the client with food and the client becomes more okay. The clients will calm down. Other than that, there's no medication you're going to say that you're going to give to let them to become more calm if they are agitated.
All right.
Yes.
Thank you.
All right, boss.
Yes.
Yeah. Please, I want to find out, is there a clear distinction between Alzheimer's and dementia? That when you just see it in a question, you know that this one is dementia or this one is Alzheimer's.
Mostly is the same. Some of the questions will give you dementia, but all these things apply in dementia. So like I was saying, if you were with me from the beginning, I said that dementia is just like the problem that will result in when the person is having what we call Alzheimer's disease. So Alzheimer's disease itself is actually the condition that will result in what we call dementia, where they have that memory deficit. So it's very, you can, in other books, they will take Alzheimer's out and then you see they will be treating what we call dementia, but it's the same thing. Just that the condition itself, what will result in dementia or Alzheimer's disease will lead to the person experiencing what we call dementia, where the memory deficit, the confusion and all that comes in. So you can apply whatever has been discussed here to dementia if you meet a question on dementia.
All right, thank you.
All right. So let's go into the eating disorders and draw the curtain on these eating disorders and answer questions then. In fact, the two common eating disorders that I want everyone here to know is what? Anorexia nervosa and then bulimia. These two, at least we know this. We've learned this in our nursing schools even before we came here. And so we all have fair knowledge on these two eating disorders. And so let's look at what the NCLEX is going to also ask us to do. I mean, at least all those things we know, but let's go into them and then try to arrive at them. Finish these two. So the first thing we're talking about is, anorexia nervosa, where the main problem in anorexia nervosa is that the person tries to avoid eating. And so in anorexia nervosa, they don't want food. Okay, they don't want food. They are more preoccupied with weight issues or obesity. They fear to gain weight. And so the onset often is associated with stressful life events. And so you get to understand that anorexia nervosa is more common with what we call people who tend to try to want to achieve certain form of or it's more common in people who overachievers, let me use that word, overachievers. They are not able to, because they don't want to gain weight or they don't want to eat, and so they mostly pay much attention to like achieving things. Let's say the person is an athlete, engages in sporting activities, and the person's all attention is on winning games or winning race, so as to probably make their family happy, their mother happy. And so the onset is more on stressful life events. They want to get things done. Okay. Another problem of them is that they don't want to gain weight. So obesity is also a concern here. So intensely fears what you call obesity. Body image is distorted. And then a disturbed self-concept is also common. They are mostly preoccupied with foods that will prevent weight gain. And so all the time they want to prevent weight gain. They are selecting foods that will not them gain weight. So preoccupied with foods that will prevent them from weight gain, and has a phobia against foods that also produces weight gain. And so you see them when they are eating, they are selecting the foods. They don't want foods that will let them put on much weight. This eating disorder can be life-threatening. Why? Because the person does not want to eat and is growing lean. They tend to develop electrolyte imbalances. They tend to develop cardiomyopathy, heart-related problems, and then starvation. And so these people, the difference between them and then bulimia is that in anorexia, they don't want to eat at all. But when we do bulimia, you get to understand that in bulimia, they eat. As for them, they eat. But when they eat, they rush to go and then clear the food off. And so you need to understand the difference that in anorexia, their major challenge is that they are more preoccupied with weight issues and then select foods that will not make them gain weight. And they tend to also starve themselves. Okay. So on assessment for someone with anorexia nervosa, appetite loss and refusal to eat. So when you ask them, they'll tell you they don't have appetite simply because they don't want to eat. And then their refusal to eat. Appetite denial. So the same thing as what I was saying, that even if they have appetite, they will tell you they don't have the appetite. And so I just want to take some fruits. I just want some fruits and I'll be okay. And they are compulsive exercise. So they always engaging in exercise that will let them lose weight or trim down. So they engage in compulsive exercise, and these people are overachievers. So if you are here and you are an overachiever, you might end up, if you don't take care, you might end up developing anorexia nervosa. Just on the note, and everybody wants to achieve more. And they are also perfectionists. That is one thing that you can also use to distinguish between anorexia nervosa and bulimia, especially if you get a case study on this thing. They might try to bring in this thing so that you can know that is it anorexia nervosa or is it bulimia nervosa the person is having. And so this is also common in overachievers. So all the time their attention is on whatever they want to achieve. And it's also common in what we call perfectionists. And so family is also a concern here. So if you are in a family that demands a lot from, the family members, let's say, as for your family, they always want everybody to perform well in school. They always want everybody to achieve, to become perfect. Such families, the members tends to develop what we call anorexia nervosa. So family is also a concern here in terms of the overachiever and then the perfectionist. Physical, issues that these people do have, or physical alterations, they tend to develop what we call decreased body temperature. They tend to have decreased pulse. They tend to have decreased blood pressure, and then weight as well. They tend to have gastro issues like constipation, teeth and gum deterioration, as well as esophageal varices from induced vomiting. They also have what we call electrolyte imbalances, which can occur. Dry, scaly skin, especially if one is dehydrated, the skin become more dry, scaly as well. They could develop some form of, fine hair, that is lanogo, like when you give birth to a child, that kind of hair on the child's body. That is what lanogo. So they can develop what we call lanogo on the extremities, which is fine hair on the body. And then sleep disturbances can also occur. They tend to develop certain form of hormonal imbalances that will lead to amenorrhea. And so they will also have some form of cyanosis, numbness of the extremities, and then bone degenerations can all occur from people who tend not to eat or who have what we call anorexia nervosa. So these are generally the issues that will tend to happen with people with what we call anorexia nervosa. And then on bulimia. So bulimia they are also preoccupied with weight, but these people indulges in eating binge followed by pinging behaviors. So eating binge means that they eat a lot. All the time you see them eating, and they eat in large quantities. The moment they finish eating, they find a way to compensate for the amount they have eaten, that is the pegging, whereby they induce vomiting themselves, or they take medications that will help them to bring out whatever they have eaten. So it is either they are taking laxatives or they are taking diuretics that will help them to bring out whatever they have eaten. So a repeated episode of excessive and uncontrollable consumption of large amount of food, that is the binge, followed by an inappropriate compensatory action, such as induced vomiting, misuse of cathartics, that is the laxatives, diuretics, in order to help them bring out whatever they have eaten. Most clients remains within normal weight range, but they think that their lives are more dominated by most clients remains within a normal weight range, but thinks that their lives are dominated by the eating related conflict. So for bulimians, they don't really tend to have weight issues, but still they are preoccupied with what we call weight, even though they tend to remain or maintain their normal weights, but still they are more preoccupied with the eating related issues, where they eat and then they go and then try to compensate for whatever they have consumed. On assessment for these people, they also more preoccupied with body shape and weight, even though they mostly retains their normal body weight, but yes, still they are still also more preoccupied with their body weight and then shape as well. They are more, their mind is always on food. So preoccupation with thoughts of food. Let me go and eat. They eat all the time or frequently consumes foods and find a way to compensate for whatever they have taken. They tend to extreme fear of gaining weight. And so that is the reason why after consuming the food, they will go and then engage in their hanging behaviors. Consumption of high-calorie food in secret. Guilt about secret eating. So whenever you talk about the fact that they tend to engage in secret eating, then they feel more guilty about that. And then they engage in that binge pang syndrome. I've talked about that. They tend to lose weight through diets, vomiting, the use of enemas, catalytic studies, the laxatives and diuretics, what will help them to bring out whatever they have eaten. They has a need to control, yet experience feeling of powerless or loss of control. So just like I was talking about when we're doing the substance misuse yesterday, I talked about the fact that these people tend to have the fact they have the feeling that they want to stop, but they also believe that they don't, like, they are powerless in terms of controlling it. So they have the need that I want to stop this, but they are not able to. They have low self-esteem. Poor interpersonal relationships are also more common with what we call bulimias. Decreased interest, absence of interest in sex. So things that they used to engage in all the time, their minds are on food. They also tend to have mood-related issues or mood swings, electrolyte imbalances, and physical problems that I did talk about in terms of the heart rate issues, what happened, the heart rate, temperature, BP, and all that. What happens in anorexia nervosa also happens here. Now, because of their binging behavior, so because after eating, they will want to rush to go and then induce what we call vomiting. They tend to develop what we call certain scars on what we call their hands or their fingers, okay? Because they would have to put what we call their finger inside, or their hands, or they have to put their fingers inside their mouth to induce what we call the vomiting. They tend to develop what we call scars or calluses on the hand. They tend to develop enlarged what we call parotid glands, and then erosion of the tooth enamel is also common with what we call bulimias. Because of the induced vomiting, is going to release what we call acid, and that is going to cause erosion and all that, and that enamel. And they also tend to develop dental caries. And so that is some of the things I just want us to take note of, because you might meet a question where the question will be asking you, between bulimia and then anorexia, which of them do you think the person will develop enlarged parotid gland? And it's more common in bulimia because of the induced vomiting, that, and then scars that can form on what we call their hands because of the induced vomiting that they engage in. A general intervention for eating disorders or eating related disorders: you need to establish your one-on-one therapeutic relationship with your client. The nurse needs to use trust and recognize any client reluctance to establish a relationship with you. So you said that these people will tend to have interpersonal relationship problems, and so you need to establish a trusted relationship with your client. You need to have a plan concerning the client's nutritional plan. So establish a plan concerning the nutritional plan for the day. So clients might need a plan in place so that you know the amounts of food the client would have to consume a day. And so that kind of plan must be in. So nutritional plan needs to be drawn. You need to assess the clients to identify factors that result in them engaging in what we call the eating disorder. So if it is someone, the overachievers issue I was talking about, what could result in anorexia nervosa, I also did indicate that stressful events mostly precipitate to what we call bulimia nervosa. And so you would have to identify what really actually causes them to engage in the eating disorders. Encourage the client to also express their feelings about eating behaviors and then how the client also feels about body weight. You need to be accepting and non-judgmental, very, very important. And then work on exploring the concept and establishing what you call their identity. Implement behavioral modification techniques. But we said that some of them will tend to develop mood issues, behavioral problems could set in. So, behavioral modification techniques are very important. Group, individual, family therapy, also very essential in managing people with eating disorders, especially family issues. If you notice that the person is having anorexia nervosa, we said that people coming from families that demand a lot from their members tends to engage in what we call with anorexia nervosa. So it's important that you engage the family to understand if it is a family, if the problem is coming from the family line. So family therapy group and individual therapies are very important. If in a healthcare facility, the client might need to supervise the client during meal times and for a specified period of time after meals, especially those that engage in the binge pang syndrome, that is anorexia nervosa, where the moment they eat, they rush to the washroom to either go and use medication that will make them to bring out whatever they have taken in or induce vomiting. So you need to supervise them during meals time and then for a specific period of time after meals. You need to monitor their intake and output. You need to set limits for each meal. Okay, provide a pleasant, relaxed environment for eating. Monitor for symptoms of physical complications I talked about. And then when the client weight is also below 70% of the ideal body weight, you need to provide medical stabilization. So for people who, especially the anorexia nervosa, that they have indulged in the eating disorder to the extent that they've lost about 70% of their ideal body weight, they might need medical assistance. So these people sometimes will need something like intake of or giving them parenteral nutrition. Exactly, that's what I was looking for. And so they might end up relying on parenteral nutrition for some time, like TPN, giving them TPN to maintain or to improve upon what we call their diet and then achieve a certain desired weight. And so you have to provide immediate medical stabilization as an inpatient. So these people will be admitted, probably go on parenteral nutrition, IV fluids and all that to help them meet their physiological needs. You need to make sure that you are weighing them. So weigh daily at the same time using the same scale after the client voids. Weighing each day may decrease anxiety in some clients. And then when weighing the client, you need to make sure that you ensure the client is wearing the same clothing as when the previous weight was taken, so that you don't change the client's clothes that the client use for weighing. So you need to have a specific clothes that the client has to use, so that you don't probably give the clients a certain form of clothes that will influence what we call the weight. That is why you need to maintain that kind of consistency in terms of weighing your clients. You need to monitor, restore fluid, electrolyte imbalance is very, very important. You need to monitor the elimination patterns. Talk about the fact that these people could develop some gastro issues like constipation. So elimination patterns, you need to monitor it and then assess limits client activity level. Anorexia and bulimia, you need to make sure that you are assessing them and then you are limiting the activity. Probably maybe, if the person has lost weight to a certain point or a certain level, client might not be able to function appropriately. So you might have to limit the activity because you don't want to put much stress on them. And then you encourage the client to also participate in diversional activities that will help take their minds off from their weights and the food that they are mostly indulging in, especially in bulimias. suicidal thoughts, you need to assess for it and then administer antidepressant medication if it's also prescribed. Psychotherapy would also be essential to help your client afterwards. So that brings us to an end to what we call our eating disorders and then what we have to do for the first part of our class today. That's my part. The next part is for us. That is on questions, so that we try our hands on question. Okay. All right. Any question, any input on whatever I've said? All right. Then there's a question on the screen. So let's read. Coming to read so that we can see. All right. This is our Francis. You're on this side.
Thank you. I want to find about the anorexia nervosa. You said their main problem is weight gain. So what of the bulimia? What is their main problem or target of eating and then inducing vomiting?
I said that. Can you come again? Can you take your question again?
I said I said in anorexia nervosa, we learned that it's like their main problem is they don't want to be overweight or increase in weight. That's why they don't like to eat. So I want to know the other one, the bulimia. What is their main target of eating and trying to induce vomiting to lose?
So they are also they also have the fear of gaining weight after they have eaten. So they are also preoccupied with the fear of weight. Yes. So that is the essence of them engaging in those activities.
Okay.
So meaning they are also preoccupied with weight-related issues. Yeah.
Okay. So they have the same thing in common. Okay.
Sure.
All right. Sure. Okay. Thank you very much.
One distinguishing factor that you can use to distinguish between the two is the fact that in bulimia, they eat. Okay. And even if they eat excess. They eat large volumes or they consume large quantity of the food. The moment they finish, you see them rushing to go and find something to compensate for what they have eaten. So that is one distinguishing factor between the two. For the anorexias, they don't want the food. They don't want to eat. They run away from food. But for bulimia, they face the food and eat. But after eating, they want to prevent weight gain. They go on to go and then take the medications or induce vomiting to bring out whatever they have eaten.
I see that then they are worrying themselves. If you take the food and then you vomit again, you don't need to eat up.
That is why it's a disorder. See, that is why it's a problem. Then Rebecca, then Colette comes up.
Okay, thank you very much. I figured the last slide before we started the bulimia, with the management of anorexia nervosa, I saw something on vomiting. So I wanted to know if vomiting can sometimes happen with anorexia nervosa.
Vomiting?
Yeah, the last slide before we moved on to bulimia.
I didn't talk. I only did anorexia, and then I just
with the management. I think the latter part of the slide.
That is
They mentioned after they said esophageal viruses.
That is findings. It's not management.
Oh, okay.
It's like physical alterations, like physical symptoms the person will show, issues the person will show when engaging in what we call anorexia nervosa. So I said esophageal viruses from induced vomiting. So they also engage in the
so I was a bit confused there. So I wanted to establish if they also engage in that.
Yes, but it's not more common with them as that of bulimia. Yes, it's not more common with them as bulimia. Yes.
Okay, thank you so much.
All right. Then Colette, sorry if I don't get your name well, okay.
No, it's okay, Colette. It's all right, Amingo. So am I right to say that so in both conditions, the main concern is the idea of them getting weight and differentiate between eating disorders, which is anorexia and bulimia, is that in eating disorders, they don't want to eat at all, but with bulimia, they do sometimes overeat, but would make sure that they vomit it.
Yeah.
Okay, all right. Thank you.
You're welcome.
I think I understand. Yeah. Thanks.
Is there any further question here?
Hello.
Yeah, hello.
Okay. Is that Prof Amingo, or what's their name again?
This is Amingo. Okay.
All right. And just a little bit of a suggestion or an addition that I read somewhere, that with the people with anorexia nervosa, the women, the females, they do suffer from amenorrhea.
Yeah, I think I did mention it.
Okay. I got up along the line, so
Yes, it's down here. Let me show it to you.
okay.
It's here. I've underlined it here.
Oh, sorry. Then I got up, so I didn't get it.
Yeah.
Okay, thank you.
Yeah, so but you can go ahead. That's great. Okay.
Yes. So I wanted to add that to the notes.
Yeah. All right.
I think that's all about it. Thank you.
All right. Thank you too.
Hello, Senior Bingo.
Yes, Ms. Isaac. Yes. Ms. Isaac, can you go ahead?
I came across this question. They wanted to find out. Yes, I said I came across this question. They wanted to find out who is most likely, as in a model. The question was like a model, like the model. Which of the conditions is the person likely to suffer, whether anorexia nervosa or bulimia?
So based on what we've done, what do you think will be between the two?
Oh, I chose anorexia.
Is that?
I chose anorexia nervosa.
Yeah. What was the correct answer? Was it contrary to anorexia nervosa? Because it's supposed to be anorexia. Yeah.
Yes. The issue was asking the question. They didn't really provide the answer. So I like.
Yeah, it's supposed to be anorexia. Yeah, it's supposed to be anorexia because of the fact that they are preoccupied with their activities, and you know what we call the models. Okay, they want that kind of body shape where they will be looking more sexy in whatever they are wearing. Okay, and so they will engage more in what we call anorexia nervosa. So for those kind of people, they will engage in, because of, I mean, this part, I mean, they want to look perfect in whatever they are engaging in. So it's going to be anorexia nervosa for people like that, for the models, or someone is a, yeah. Are they modelers? Is that the correct word? A model. Okay. Any further inputs? So I had my question on the screen. Can we go through the questions?
So for hospitalized patients.
All right. When developing a plan of care for a hospitalized patient with moderate dementia, which intervention would the nurse include? A, provide complete personal hygiene care for patients. B, remind the patient frequently about being in the hospital. C, reposition the patient frequently to avoid skin breakdown. D, place suction at the bedside to decrease the risk for aspiration.
So impaired memory, misplaced belongings, deficits in choosing proper attire. So
Madam Grace answering for us. Madam Grace, are you answering for us?
With the moderates, we know that they have memory loss. So activity of daily living will be a problem. I would go for A.
Thank you.
Provide complete personal hygiene care for the patient.
Okay. Thank you. Let's look at those with let's go in for the B. Ms. Aisi, your hand was up.
Yes. So
Boss Amigo.
looking at they said moderate dementia, moderate.
Yeah, moderate. Can you say what you said again, Ms. Aisi? I didn't get you. I only heard the moderate dementia. Oh, Ms. Aisi's line is not helping.
Hello.
Yeah, Ms. Aisi, go ahead.
Hear me? Hello.
Yes, Ms. Aisi.
Yeah.
Aisi, connect again. Connect again. Let me connect again when your line is.
Hello.
Yes.
Okay.
Oh, so you can hear me.
Your line is breaking, Ms. Aisi.
Yeah.
So you reconnect again so that let Mr. Isaac come in so that when you join again, you talk, okay? Mr. Isaac, kindly go ahead.
Pertaining to the 4 is with respect to dementia. I'll go for my answer would be B, because moderate would actually be the second, because there is mild, there is moderate to severe and severe. Yeah. So I would go for B, because at this point, usually what they easily forget, so you have to continually be reminding them about things and their environment.
Okay. All right. Thank you. So Mr. Isaac is going for B. Yeah, no, Rebecca.
Yes, I also go for B, because going through your slide, we were able to establish that with mild is characterized with forgetfulness, and then the moderate was with confusion. And then when you have an encounter with people at this stage, they will the most questions they will ask you is, what am I doing here? Where am I? Like, those are the questions they mostly ask. So I'll go for B.
Okay.
We have to keep reminding them.
All right, thank you. Mr. Isaac, are you back again?
Yes, and I'm saying that the A and the C, they are talking about like someone who cannot actually care for himself or herself. It's a provide complete personal hygiene. And then here we're talking about moderate dementia. And then the answers are more relating to maybe say 3 or 4. Okay. Now, providing complete personal hygiene care. That means that the person cannot care for himself. And then the same way for C, reposition the patient frequently to avoid skin breakdown. That means that the patient needs assistance. Yeah.
Okay. Okay. All right. So Mr. Izzy has also come in. Now we heard him clearly. There was another hand. Madam Comfort, let me let you come in before I present my answer. I think your hand has been up.
But yeah, so I also go for the B, because with the moderate, we learn that they have confusion. So when they are confused like that, you have to always remind them of wherever they are and what they are doing at the particular place. So I'll go for the B.
Okay, thank you. So I think if Mr. Idris, you want to come into all right. Let me hear of Mr. Idris so that we make progress.
Yeah, I also go in for the B, because they need to be frequently reorient for wherever they are. That's why I'm also choosing B.
Okay. So I think we can make progress, okay? And exactly as they said.
Someone is making launching this complaint
on the page,
on the page. That
guys, she cannot. She finds it difficult to join. Probably her network. I think it's her network. So the answer is B. frequent reorientation of your clients at moderate, not remember at moderate, I said that they require some form of help, but not complete. Okay. So that is why the B is the best answer here. Let's go. I talk about delirium, so I'll do this. When administering a mental status examination to a patient with delirium, the nurse should A, medicate the patient first to reduce anxiety. B, give the examination when the patient is well rested. C, reorient the patient as needed during the examination. D, choose a place without distractions, without distracting environmental stimuli. This is very straightforward. And I believe this is straightforward. Right? Okay. So this is a straightforward D. Okay. Everyone, yeah, we know that. In this instance, if you are going to do your mental health assessment, mental status assessment, you need to make sure the environment is non-distracting, a serene environment, no form of distraction in the client's environment. So that is the straightforward one. To protect a patient from injury during episodes of delirium, the most appropriate action by the nurse is to A, secure the patient in bed using a soft chest restraint. B, ask the healthcare provider about ordering an antipsychotic drug. C, instruct family members to remain with the patient and prevent injury. D, assign a nursing assistant to stay with the patient and offer frequent reorientation. Okay, so see people going for D. Why are we choosing D here? Why? Is it not A? Is it not B? Is it not C? Is it not? And we are going for D.
Can I
I'm
try?
only curious.
Can I try, Amingo?
Okay. So I think we all agree that a D would be the most appropriate intervention here for you, the nurse, to do for this client at this point. Assigning them a nurse assistant to stay with their clients, so the nurse assistant can monitor the patient and offer frequent reorientation to the patient. A 72-year-old patient is diagnosed with moderate dementia as a result of multiple stroke. During assessment of the patient, the nurse would expect to find A, excessive nighttime sleepiness, B, difficulty eating and swallowing, C, variable ability to perform simple tasks, D, loss of both recent and long-term memory. Getting the D's, getting the C's. Who's also going for B? So those of us with our answers as B, sorry, as D and C. Why the differences in what? Why are we going for D? Why are we going for C?
I'd say I picked C because A and B I'll probably say are more severe rather than moderate. And then obviously not D because D says loss of both recent and long-term memory. They do have some sort of memory loss, but I wouldn't say it's both recent and long-term. It's my idea. I'm not sure.
Okay, that's fine. All right, so she's going for C. She thinks C is the perfect one. The D's. Tell us why you're going for G.
Yeah, boss, I mean.
Yeah, hello, C.
Yeah, I couldn't go for D in a sense. I think D look like a severe dementia. They have loss of both recent and long-term memory. So the moderate is, to me, is applicable to the C.
About to C. Okay. Still waiting for the D's to defend their answer. As I was saying, I mean, I always know my answer, but I'm not able to express myself or tell why I'm going for. All right, so I wanted the D's to defend their answer, but they could not do that.
But
you didn't defend your answer. Now that you are coming in, Mr. Yusuf, yes.
Please, is it the case that before one could be diagnosed as having dementia, you should have loss of long-term memory? Because for every normal person, we do have recent memory loss sometimes. Hello.
Yes, I get you.
Yes. So is it the case whether moderate or severe dementia it start with loss of long-term memory? Is that the case?
All right. So yes, once in a while we do have issues with memory loss, okay? But these people, their issues are more different than our own, okay? In terms of their memory loss, it's more frequent. Sometimes, even when normally you forget about something, you do remember it, okay? But that's why I'm saying that before you diagnose someone of having dementia, you might have ruled out any form of issue causing the person to experience the things we talk about. And when it comes to so that's why it says both recent and long-term memory loss. With the memory loss we do encounter, it's just a transient one. I mean, you will be able to even recover or recollect whatever you were trying to remember. That doesn't fall within this kind of amnesia. Okay, I don't think that Mr. Yusuf, you encounter amnesia. What you encounter is some form of transient. I mean, just forget about something later. You can just remember it. But these people, they will forget. They will not even be able to recollect whatever they forgot about. And the reason why is it's not the first stage. It's not a mild one, because the mild one, they might be able to probably retain recent information. However, maybe long-term information is what they will not be able to, recollect. The moment they get into the moderate, that is stage 2, they will tend to forget both recent one and then the long-term one.
Yes, I think they have a time duration. So that's why we have those types of amnesia, like retrograde
Yes, sure.
amnesia.
Sure.
Yeah, those like those things like
it has time bound to it. You know, the more you forget about some within some few minutes or so, you'll be able to recollect whatever you forgot about. You get me? A 62-year-old patient is brought to the clinic. Yes, Madam Patience. Madam Patience, kindly go ahead.
Yes, sorry.
Oh, okay. A 62-year-old
Hello,
patient.
sir. Please, so
Yeah.
I beg you. So this one, the previous one, what was the answer? I didn't really get the answer.
The answer was on the screen. Or you worry for this is the answer.
Oh, okay. Okay, thank you.
All right. A 62-year-old patient is brought to the clinic by a family member who is concerned about the patient's inability to solve common problems. To obtain information about the patient's current mental status, which question should the nurse ask the patient? A, where were you born? B, do you have any feelings of sadness? C, what did you have for breakfast? D, how positive is your self-image? Very easy, straightforward one, right? So who is answering for us? Why are we going for C? I'm just curious about why we are choosing C.
C because most the answers, it tends to be the most, let me say, the most easiest or something the person ideally should be able to tell. Where were you born for a 62-year-old person in question can be too much for the person at that time, especially with the person's mental status, pertaining to the person's mental status. But at least for what you had for breakfast, depending, let's assuming the person was in the hospital, let's say in the afternoon, I think the person in question should be able to tell what he or she had for breakfast.
Oh, okay. That's fine. So it's recent. We want recent information. So all right. Okay. A patient with I did this patient somewhere the last time and it was funny to me. Let's go to this question. A patient with mild dementia has a new prescription for Aricept, that is the Pezil. Which nursing action will be most effective in ensuring compliance with the medication? A, having the patient's spouse administer the medication. B, setting the medication up weekly in a medication box. C, calling the patient daily with a reminder to take reminders, take the medication in the patient's house.
I think it's D.
Yes. Someone wants to come in.
Yeah, the reason is that
so which one are you going for, Mr. Isaac?
D.
You are going for B.
D for dog.
D for dog. Okay.
Yeah, D. Okay. The reason is that with the mild dementia, that tends to be the very first stage or the early onset. And with that, posting reminders to take medication is more appropriate. When you're looking at having the patient's spouse administer, which means the person is at the stage whereby he or she might have totally lost their memory, and setting up the medication weekly in a box, looking at the time frame is long. And calling the patient daily, usually I think will be at the stage of moderate or moderate to severe. So I think D is more appropriate.
Okay. All right. He has perfectly defended his answer, giving us his rationale. Yes. The A's and the B's. Let's go. If you are for A, tell us your reason for choosing A.
Sorry, I think I went for A.
All right.
Hello?
Go ahead.
Can you hear me?
Yeah,
Sorry.
kindly go ahead.
I think I went for A because B was, as much as you're setting up the medication in the box, it doesn't guarantee if the patient is gonna remember to take it. C, calling the patient daily again, I don't know, it's not certain that they will take it, as well as D. I know A is, yeah, I think A for me, I think.
Okay, that's fine. I get your point. She's going for A. Mr. Isi, which one are you going for?
Yes. Let me use my personal experience when I went for the mental health affiliation to answer this. Usually,
Okay.
what they were doing that, like they were having times, maybe at 2 o'clock medications, they will call them, put all the drugs with their numbers. Each client is assigned to a number. So you know that you are 1. This one is 2. So they will be in line. So when they come daily, that's what they do. You come, I'm 1, then you pick your drug. So with that one, I'm going to go for C.
Were they dementia? Were those patients dementia patients?
No.
Oh, one question.
Let's hear from Ohinadepa.
Yeah, boss.
Yeah, Ohinadepa, go ahead.
So I'm thinking I'll go for B. Because with A, having the patient's spouse administer the medication, we are talking about
mild dementia here, and we want them to be independent as possible. So letting someone to give the medication to them is like you're making them like dependent on somebody.
Incapacitated or something like
Yes.
that. Okay.
Yes. So setting up the medications weekly. So what I've seen with some elderly people is that they have like containers that they've written maybe Monday, Tuesday, Wednesday. So they set the medications into it. They're in the pot. So once you take it, you know today is Monday. So you just open and take what is in the Monday box. Yeah, so I'll do B because calling the patient to remind them and posting reminders, like both of them are the same thing. So automatically I'm taking both of them out of the picture. Thank you.
All right, you're welcome. So the answer is A. Now, this is why B is wrong. Now, when you do that, you are bringing in a new skill for the client to learn. Dementia people cannot learn new skills. No matter the stage the client finds him or herself in, they cannot learn new skills. We said that they retain the ability to perform self-care activities. This time around, you are saying you are setting up a medication. You are setting the medications up weekly in the medication box. That is new thing you are introducing for the person to do. And the person might not be able to really go strictly according to how you want the person to take it. And so the reason why the most appropriate action for you to ensure compliance with treatment is to have the patient's significant other, being the spouse, to administer the medication. Last time someone asked a follow-up question, what if the patient is not having a wife, or it's not having a spouse? And I said that people who have dementia, dementia patient will never stay alone. That is why if the family cannot take care of the person, they send the person to the long-term care facilities for the patient to be taken care of. So a dementia patient will definitely need help or assistance from either a relative or whoever is in charge to take care of the patient. So that is why A is the most appropriate action here.
And I think the key is compliance. I think the key word was compliance, making sure that they take it. Yeah.
Sure. So we are good to go, right? Which intervention would the next...
Zoe, check if daddy is sleeping or he's talking.
Was Miss Watson talking to us?
He's talking to your daughter.
Okay, it's not easy. Which intervention will the nurse include in the plan of care for a patient who has late-stage Alzheimer's disease? A, encourage the patient to discuss events from the past. B, maintain a consistent daily routines for the patient's care. C, reorient the patient to the date and time every 2 to 3 hours. D, provide the patient with current newspapers and magazines. All right. So see that we've already going for our B. So straightforward, no one has a varied view on this, right? Maintaining a consistent routine for the patient care is very important at this point. So the B is the perfect answer, or the best answer here to choose. this infection.
Hello.
Yes, hello.
Your rationale, the last part. Do you mean that they can read, they can see, but they can't read? And
they
the patient
can't.
will not be, they can't read. The last part, you said they can't read.
Yes, they cannot read. They cannot be able to read.
Sir. Oh.
And the patient will not be able to read. Reorientation of time and place will not be helpful to the patient with late Alzheimer's. Now, that option that is talking about in the D, provide the patient with current newspapers and magazines. Late Alzheimer's, I mean, everything is gone. Can the patient even see and read? So it's that statement is related to option D. Late Alzheimer's, they can't read. Profound memory loss. These people cannot even do anything. I need the eating disorder. So these are all still on. All the things are many, wondering. When assessing a patient with AD who is being admitted to a long-term care facility, the nurse learns that the patient has had several episodes of wandering away from home. Which nursing action will the nurse include in the plan of care? A, place the patient in a room close to the nursing station. B, ask the patient why the wandering episode have occurred. C, have the family bring in familiar items from the patient's home. D, reorient the patient to the new living situation several times daily. Yes, so what do we think is the answer for this very section?
Talk.
No, you go.
One at a time, okay. So Mr. Ace, if you go so that when you have
Okay, then let me talk. They need close monitoring. So that's why I'll choose A. Place the patient in the room closer to the nursing station. So that's why I went for A. Other patient why they're wondering if it will have. Okay, this one is not necessary.
Okay. All right. Then let's go, Madam Collins.
I think just like what he said, the main concern was that they're wandering. So having them closer to the nursing station just means that the nurses can keep an eye on him. The other answers are not really, they're not resolving the problem, basically.
All right. Okay. So I think we can all agree to them that placing the patient in a room that is close to the nursing station is very important so that you can provide close supervision for the client. So it is due to the fact that you need to provide close supervision, one-on-one supervision with your client. That is why you would have to go in for the option A. Yeah. All right. During the morning change of shifts reports. During the morning change of shifts reports at the long-term care facility, the nurse learns that the patient with dementia has had sundown. Which nursing action should the nurse take whilst caring for the patient? A, provide early orientation to time of day. B, move the patient to a quieter room at night. C, keep blinds open during the daytime hours. D, have the patient take a brief mid-morning nap. Hmm. Hmm. Yes, Ajia. Ajia, sorry, Ajia. Kindly go ahead.
Okay, so during the presentation, you said sundowning mostly occurs late afternoon.
Hmm.
And so during the morning shift, I think have the patient take a brief mid-morning nap so that during the late afternoon they can go around and do their things.
Okay, she's going for D. Who else has something else to tell us?
C, it's like CO.
Mr. Isaac, are you going for C or is it like C? Why are you going for C, Mr. Isaac?
Keep the blinds open during the daytime hours.
Mm-hmm. How do you understand that option?
But I want to, but if I'm going to answer it this way, it's going to send me back to the initial question that I asked.
Yeah.
So you see that, but that's still, I don't know. It is still in my mind that keep blinds open during the daytime hours, so that
okay.
To make the client active.
Okay.
Mm-hmm.
Now, yeah, okay, I get you. Is there anyone who wants to also come in? I made mention that I don't want to talk because so I wanted Mr. Isaac to explain that option for us again. Keeping blinds open during the daytime is preventing shadow from throwing into the client's room. Remember I told you that shadows into the room, it mostly leads to what we call the patient experiencing sound learning. So you need to close the blinds, the curtains. That's why. So, but they didn't use the curtains there. So keep blinds open during the daytime. Okay, means that you need to close what you call your curtains, but they do like using that and keep blinds open so that you close. Your window so that what is it? Shadows cannot enter your room. So that is what that statement all means. Okay.
Samingo, please come again, okay? Keeping the blinds open. Yeah.
I'm saying that keeping blinds open is the same as having your curtain open up so as to prevent shadows from being thrown into the room. Because when I was doing sound dining, I did mention that one of the things that mostly precipitates or brings about sound dining is when you have shadows in the room, especially in the late afternoon hour. And so in order to do that, you need to close your curtains up. But I'm saying that they tend to use the word blind opens. So that is like blind curtain, that kind of thing. So you keep the blinds open during the day. That is to help prevent shadows from entering the room, to prevent what we call sound down. Now, when the client takes what we call the taking a nap will interfere with nighttime sleep. So that is why I was saying that I'm not going to use a nap in my statement when Mr. Isaac was pushing me to use nap. So we don't encourage nap taking. If you take nap, it's going to affect the client over the night. The client will not be able to sleep. And then the wandering will happen. So that is it.
Domingo.
Yes.
Please, how does the shadows increase the sundown? Is it that you see?
That's your assignment, Mr. Yusuf.
No,
Go and read on that.
let me ask maybe someone can help.
That's your assignment. I want Mr. Yusuf to go and read on that.
Okay.
Madam
Hello.
Grace, go ahead. If not,
Well,
Mr. Yusuf
maybe
will
I
beat
can
me.
help.
Madam Grace, go ahead.
So with the sundown, and sometimes they become agitated, they become restless. So with that, it makes them wonder a lot as well. So you keep the curtains during the day open, and at night you close it. So there's agitation. In short terms, there's agitation during sundowning.
The shadow throws into the room, they feel more
Yes,
agitated.
irritate them.
Irritates them, exactly.
Yes.
So that's the correct word. That's your assignment. It's still your assignment.
So please, so if I get you right, so during the daytime you have to close the curtain or you have to do what? I didn't get
Opening
that.
the curtains means that you are opening it like wide. When you close, close curtains. When you close curtains, like you folded it. Is that not the case?
Yes.
So shadows will enter. So when you open it, you are closing, you are opening it to prevent shadows from entering the room.
Okay. To block the sun.
To block the reflection.
Oh, okay. I get it now. Okay, thank you.
All right.
I'm sorry. Could you just go back for 1 second, please? I'm really sorry.
Is it this or
the answers?
This is the question.
Okay, thank you. Yeah, that kind. Thank you.
I wanted to do eating disorder, so let me skip this. Let me look for eating disorder question. Okay. So let's do 1 or 2. I think the rest are on eating disorder. We'll close in about 5 minutes time. So a high school senior is diagnosed with anorexia nervosa and is hospitalized for severe malnutrition. The treatment team is planning to use behavioral modification. What rationale should a nurse identify as the reasoning behind this therapy choice? A. This therapy will increase the client's motivation to gain weight. B. This therapy will reward the client for perfectionist achievement. C. This therapy will provide the client with control over behavioral choices. D. This therapy will protect the client from parental overindulgence. This one there. The option itself explains itself with a question, right? So yes, it will help them to make choices in terms of their behavioral issues to control over behavioral choices. It's straightforward. So behavioral modification programs will help them in terms of controlling their choices and all that. That's a straightforward. Yes, there's another one. Family dynamics are thought to be a major influence in the development of anorexia nervosa. Which information related to a client's home environment should a nurse associate with the development of this disorder? A. The home environment maintains loose personal boundaries. B. The home environment places an overemphasis on food. C. The home environment is overprotective and demands perfection. D. The home environment condones corporal punishment. This one too is also very straightforward. If you've been with me from the time I was doing what we call anorexia nervosa or the eating disorders. It's also straightforward for us to tackle it. Yes. So it's also C, right? That's it's more common among families where a lot of demand is placed on the family members in terms of being perfect, and then you having to achieve whatever they have target or whatever target they have set for you, need to achieve it. So these people tend to indulge in what we call anorexia nervosa. Another one here. A client's altered body image is evidenced by claims of feeling fat, even though the patient is emaciated. Which is the appropriate outcome criteria for this client's problem? A, the client will consume adequate calories to sustain normal weight. B, the client will cease strenuous exercise programs. C, the client will perceive an ideal body weight and shape as normal. D, the client will not express a preoccupation with food. So, which one is also the perfect for us, or the most appropriate outcome criteria for such a patient? A. Why going for A?
Okay, so the client is emaciated, so she needs more calories in order for her to have an ideal weight, to gain weight a bit and have
okay.
A normal weight. Yeah.
Okay. Who else? Those going for the C. Why C?
We are dealing with outcome criteria. So the outcome criteria for a client who has a body image changes, feeling fat, will best outcome criteria for such a client should be C. The client will perceive an ideal body weight and shape as normal. That to say that initially, even if their body were normal, to them, they will see it as not. So they will indulge in these behaviors. So the outcome criteria is to ensure that they see it as normal.
Okay, thank you. Saisif has given us this reason. It's okay. Is there anyone with a different view? The person is ready to share with us. Yes, Mr. Paul.
But I will go for the A because the patient we are dealing with is anorexia nervosa, and their main problem is about eating. So if we are going for the C, the weight, what will bring the weight up? And even when we follow the muscle, you have to start from the physiological, which is the food. That's why I'm going for the A.
Okay. Mr. Port is going for A. All right. My God.
Oh, the nurse should identify the appropriate.
Yes, Esther. Yes, hello, Esther.
So you've shown the answer, so I think.
Okay, you
I was
wanted to.
going for C, yeah.
You wanted to contribute. So yeah, so is it these people? We said that their major problem is what? Body weight, preoccupied with issues of body weight, and it's because of their body weight that is why they tend to indulge in the eating disorders to lose weight. And so if you have someone who is saying that, I mean, the person is preoccupied with the fact that, I mean, he or she is feeling fat, even though, there's evidence to show the person is emaciated. The problem is body weight. The problem here isn't about as to whether the person is eating or not. The problem says that altered body image. This is care plan you are drawing for a patient. And so your outcome criteria should be targeted on the body weight or the body image. And so out of this, it is the perceived and ideal body weight and shape as normal. That is what should be your outcome criteria when you are preparing your nursing care plan for this patient. It's not about the food. At this point, it has not even been stated that the patient is not consuming food. They have not talked about the fact that the patient is not consuming high calorie food or whatever. It is that the patient is perceiving his or her body as being, fat. And so your outcome criteria should also be targeted towards the fact that patient will see him or herself as having an ideal body weight and then shape as well. I think we do this last one and we leave it there. We are almost 6:20, so we leave it there. Then we meet again next week and continue what we are doing. A nurse observes dental deterioration when assessing a client diagnosed with bulimia nervosa. What explains this assessment findings? A, the emesis produced during purging is acidic and corrodes the tooth enamel. Purging causes the depletion of dietary calcium. C, food is rapidly ingested without proper mastication. D, poor dental and oral hygiene leads to dental caries. So this will be our last question for the day. And I think others are already answering that they are going for A. And so that brings us to an end to today's class. So A is the correct answer. I think I didn't even mention it when we were talking about bulimia nervosa, that because of their indulgence in inducing vomiting and all that, it produces, or the emesis contains acid, and so could result in corroding the enamel, leading to them having the dental problem. So that brings us to an end to our discussion for today, and I will leave it here for today unless someone has